All right. We're going to go ahead and get started we're going to have committee A and B. We're going to do first before we start our session. Mr. Landau, if you want to start, first we'll have Justin do for committee A. Okay. Do a roll call, please.
Okay.
Or go ahead.
I need to call to order first.
Call to order first.
Okay, I'll call to order committee A. Justin, do you want to call the roll?
Mr. Landau.
Aye.
Dr. Maiden.
Present.
Dr. Speakerman.
Present.
Okay, the first order of business is the minutes of our meeting on June 15th, 2019. Dr. Speakerman wasn't here, so Dr. Maiden, I entertain a motion to approve.
I'd like to make a motion to approve the June 15 minutes, Committee A.
I'll second. Any discussion? Hearing none, all in favor indicate by saying aye.
Aye.
Opposed? None. The ayes have it. The next order of business is the consent agenda. We have items 1 through 4. Is there any request to remove 1 through 4 from the consent agenda?
No such request.
Okay, then I will entertain a motion to approve the consent agenda.
I make a motion to approve the consent agenda.
Okay, these are for consideration of executive director dismissals. I'll second. Any discussion? Hearing none. All in favor indicate by saying aye.
Aye.
Opposed? None. The ayes have it, and we are adjourned.
Perfect.
Thank you.
All right. So next will be committee B. If you want to call it to order.
Yep, I'd like to call committee B to order. Justin, can I have a roll call?
Yes. Mr. Berg.
Here.
Dr. Erbstrasser.
Here.
Dr. Reese. Okay.
And then if you want to have a motion for the minutes.
Yeah, I would like to have motions for the approval of minutes for June 15th of 2019.
So moved.
Second. And it's the May 18th too?
Do one at a time.
Oh, no. We're talking about the committee B minutes, agenda minutes, not the regular.
Well, my computer's kind of.
Is it up?
Oh, here. I'm sorry. Do you want to go on that?
Well, it is now.
Well,
I can just use this one here.
But you have, okay.
Yeah. Okay. Well, yeah. Okay. So review and consideration, we already did that. Consent agenda for the consideration of executive director dismissals.
Okay.
Do I have a motion?
So, yes.
Second?
That's you.
Okay. Can I have a motion for adjournment?
Is there any, first you have to vote and say, is there any of the items that you would like to have removed from the agenda to go to investigative hearing or not? If hearing none, then can I have a motion?
Can I have a motion? Is there anybody that would like to keep a case or remove? Do I have a consideration for removal of A through J?
Okay. Hearing none, can I have a motion then?
Second.
So moved.
Okay, great. Then to have a motion for adjournment.
Motion for adjournment.
Vote? They voted.
Need to vote.
Okay, go ahead and vote.
Just say all in favor.
All in favor, say aye.
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 Perfect.
So adjourn. Can I have a motion for adjournment?
So moved.
Okay.
Good job, guys. Great job.
Well, I don't even have this. My computer wasn't up.
I know.
Good job.
There's your thing.
All right.
I'm looking.
All right. Is Dr. Erbstrasser, are you on, or do you need him? You need help?
I'm getting on right now.
Okay. Are you guys ready to get started then?
Yeah.
Okay. Justin, are you ready?
I'm ready.
All right. Good morning, everyone. We're going to call this session in order today. Welcome. Can I have a roll call, Justin, and a review of the agenda?
Yes. Mr. Berg.
Here.
Dr. Speakerman.
Here.
Dr. Reese. Dr. Maiden.
Present.
Mr. Landau.
Present.
Dr. Erbstrasser.
Here.
Dr. Cunningham.
Yes.
We have a quorum, and there's no changes to the agenda.
The mission of the board is to protect the public by setting educational and training standards for the licensure by reviewing complaints made against osteopathic physicians, interns, and residents to ensure that their conduct meets the standards of the profession as defined by law. I want to welcome the medical students that are here today. Do we have med students from Midwestern? Put your hand up. Wow. Got a lot of people here. Welcome. Anybody from AT Still? welcome as well. Anybody else that I haven't heard, any of the other med students I haven't heard about. I hope this will be a learning for you today. Please put your cell phones away. We're going to have you come up and talk to us afterward. I am the chair of the board. I have Mr. Landau. He is a judge. He is our public member, and he's the vice chair. We have three physicians, Mr. Madam, Dr. Madam, ER physician, Dr. Erbstrasser, family practice, and then Dr. Speakerman, who is a pediatrician. And then we also have Mr. Birch, who's our other public member. We have two investigators, Dr. Pra, and also John O'Shattenberg as well. And then we also have then our esteemed Attorney General, Jean Galvin, who keeps us all in line, especially for me. She even brought me some York peppermint patties to keep me in line today. And so then also I have Justin, who is also our executive director, and all of our staff, Kimberly and everybody else. Thank you for all that you do. So again, I hope this is a learning for you as well. Next, let me go to next. If there's any member of the public who is not a respondent, licensee, or applicant or complainant wishes to address the board on a matter that appears on the agenda, you will be asked to speak during the call to the public. If you want to address the board on an issue that's not on the agenda, you will be asked to speak during the call to the public, and all those wishing to speak should fill out a speaker form and give it to the staff member. Do we have anybody here? All right.
Not at this time.
All right, so we'll move on to 4. This is review and considerations and approval of minutes. Justin, first we're going to go to A, May 18, 2019, open session. Is there anybody that needs to recruit that we have to?
For the May 18th minute, Mr. Landau was absent.
Here.
Okay, Mr. Landau was not here. Has everybody had a chance to review those open session meetings?
Motion to approve.
Motion to approve. Can I have a second by Dr. Speakerman? All in favor signify by saying aye.
Aye.
All opposed, same sign. We'll move on to B, May 18, 2019, executive session. Again, is it Mr. Landau that has to recuse?
I wasn't here.
He was not here. Has everybody had a chance to review those?
Yes.
Can I have a motion?
Motion to approve.
Motion approved by Dr. Madam. Can I have a second?
Second.
Second by Dr. Speakerman. All in favor signify by saying aye.
Aye.
All opposed, same sign.
I'll have to call a second call to the public.
C, we're going to go to June 15, 2019, open session. Is there anybody else that we have to?
Dr. Speakerman was absent from the June meeting.
Will recuse himself. Have all those had a chance to review? If so, can I have a motion?
Motion to approve.
Motion approved by Dr. Madam. Can I have a second?
Second.
Second by Dr. Erbstrasser. All in favor signify by saying aye.
Aye.
All opposed, same sign. And then we'll go to D, June 15, 2019, executive session. Again, Dr. Speakerman will have to recuse himself. Has everybody had a chance to review those? And if so, can I have a motion?
Yes. Motion to approve.
Motion approved by Dr. Madam. Can I have a second?
Second.
Second by Dr. Erbstrasser. All those in favor signify by saying aye.
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 All opposed, same sign as well. All right. Where would you like us to go from here? We're going to...
So if we'd like to go to 5A, which is the motion for rehearing.
All right. So 5A, motion for rehearing. I will recuse myself from this case. I will have Mr. Landau, who is the vice chair. He will take over this case, and I'll let him move into this. Okay? And if you guys will call me when you're finished.
Maybe. Okay, as soon as my computer does what it's supposed to do, we will be okay. Give me a moment here.
Which one is it?
That's the
Here we go.
first section. It's
This is it's DO 18-0044A, in the matter of Dr. Karen Borgeson. This is a motion for rehearing. You able to find it, Dr. Erbstrasser?
I'm still here.
He's logged out with
I'm
Sharon.
logged on with him.
Oh,
We're
okay.
computer buddies at this time.
Okay. Is Dr. Borgeson here? Okay. Is there anyone here representing Dr. Borgeson? Okay. I do not know. Mr.
I
Chief.
thought I saw her go into one of the
Okay, maybe she's there with her attorney, so let's go ahead and check.
What is the irregularity of the proceedings? I have no idea.
No? Okay. Before we begin, just as a bit of an explanation, a motion for rehearing is a post-hearing legal motion where we do not take any testimony. The physician in this case can argue as to why the case should be reheard, and the action by the board basically not hold, and basically send the case back to the board for a rehearing. So since we do not take any testimony, but we do have one person wishing to speak, I am going to insert a call to the public. And if there's anyone who would like to make a comment to the board, this is the opportunity to do so. We cannot take any action on the comment, but we can listen. And I have a speaker slip from Dr. Don Cunningham.
Initials.
Is Dr. C here? I couldn't see back there. Okay, Dr. C, if you could please come forward. And just take a seat right over there to my right, your left. And please go ahead and remind the board members that we cannot ask any questions. Dr. C, please. Welcome. Good morning.
Good morning. Thank you for allowing me to be here today. We had filed the complaint against Dr. Borgeson, and my wife had gone through a lot. She had a surgery that was supposed to be a short stay back 6 years ago to remove a gallbladder and an appendix, and it ended up that she had to have 6 surgeries, and she was hospitalized for 3 months. She was in intensive care, ICU, and we just felt that the care and the follow-up was inadequate, and we are just requesting, my wife and I, that the sanction that she had when we were here before be maintained.
Okay, thank you very much. I appreciate you being here.
Yes, sir.
Okay, you can take a seat back there if you'd like, wherever you would like. And for the board, we have the option of granting the motion for rehearing, granting the motion for rehearing in part, or denying the motion for rehearing. Is there any discussion? Seeing no discussion, I'll entertain a motion.
Mr. Landa, what is I'm unfamiliar. This is the first time I've had this happen. So, what is Dr. Borgeson asking of us specifically? What did we do, and then what is he asking us to do now?
In the hearing, we issued and let me bring it up here because there were 2 separate findings.
Yeah, I just want to see what we're looking at.
Yeah.
Because it was like I retained sponge and all that. I mean, I remember the case.
Yeah.
The board issued an administrative
Yeah,
warning.
I'll take care of it. It's okay. Let me go through it. The board issued in one count an administrative warning, which is disciplinary action.
Okay, so, and that goes on file with the state board and
Right.
the national deal? Okay.
Yes, and that was for the failure to follow up.
Uh-huh.
And for the post-surgical action. On the sponge issue, a letter of concern was issued, which is non-disciplinary
Okay.
action.
So essentially they would like to have it go back so that we read here it to be non-disciplinary. I'm imagining is the...
Yes, the argument made by Dr. Borgeson was one, that there was an error in the proceeding by allowing Dr. Friedman to speak, and number two, that the facts presented and the evidence presented do not justify the disciplinary action or the letter of concern. Those were the two arguments.
If I may clarify.
Thank you.
The letter of concern is non-appealable, so they're
Yeah.
only asking for a rehearing on the administrative warning.
Okay. I would go against that. I think it's fair.
Okay.
What we did?
I think we thoroughly investigated this case, and we came up with a decision I think that was really quite fair. So I don't see any reason to retry this.
Okay, any other comments? Then I'll entertain a motion. The motion could be to grant the rehearing, or the motion could be to deny the rehearing.
I'd like to make a motion to deny the rehearing.
Okay, a motion is made. Is there a second?
Second.
Motion made by Dr. Madim, second by Dr. Erbstrasser. Is there any discussion among board members? Hearing none. Do you want a roll call vote, Gene?
Yes, please.
Okay, we have a roll call vote, please.
Mr. Berg.
Aye.
Dr. Speakerman.
Aye.
Dr. Madim.
Aye.
Mr. Landau.
Aye.
Dr. Erbstrasser.
Yes.
Okay. And Dr. Cunningham recuses, and Dr. Reese is absent.
Okay, therefore, by a vote of 5 ayes and 0 nays, you have denied the rehearing, and that concludes this matter.
Thank you.
Okay.
Thank you, Mr. Landau.
Thank you, Dr. C. Thank you for coming. And anyone else who was here to watch this, thank you for coming. And we'll get Dr. Cunningham back here, and we will move on to 6A, I believe, when Dr. Cunningham rejoins us.
How's everybody doing? Do we need a break for biologic break, or are everybody doing okay?
Good.
All right.
Hopefully.
Okay. Remind everybody we're still in session. We're to 6, review and discussion and action. This is for review of allegations of unprofessional conduct. These are case reviews. This is not where we're going to go into and examine each case in depth. What we're looking at this is to just see if there's enough information that we want to move this forward to an investigative hearing. So the first case is A, DO-17-001B, Catherine Kin Yan Ho, DO license number 006189. Is Dr. Ho here?
Dr. Ho is signed in to speak, as well as her attorney, Mr. Myers.
Okay, please come forward. All right. Justin, Gene, we don't need to swear anybody in here because this is not an investigative hearing, do we?
That's correct.
Okay. Welcome, Dr. Ho. And if you would introduce your attorney with you for everyone in the room.
This is Mr. Steve Myers.
Welcome, Mr. Myers. And so, all right. I think that there were a couple, I can't remember who the people, I'm going back here, just give us a minute here.
Well, I was
Dr. Maiden was one of them, and who had questions, and then Mr. Landau as well in this case.
Dr. Cunningham.
Yes, sir.
Excuse me. After the presentation, the doctor has some prepared comments, and I have some comments, too.
Steve, this is an investigative hearing, so we're just looking to see if we want to move this forward to an investigative hearing or not. So they're not going to review the case or anything like that, all right?
Yeah.
So this is just, if they have questions and they want to move it forward, then we'll go forward from there, okay?
We're here to persuade you not to go forward.
Okay. Dr. Maiden, did you have a question? Because you were one of the reviewers of this case.
No, I don't have so much of a question. And I'm not saying that you had a violation of statutes. This is not a judgment upon you, but there were enough questions raised that I could not see a way to avoid going to an investigative hearing.
Okay. And then Mr. Landau?
Yeah, I know there's been, this practice has been before us a number of times, and the differing comments by differing members of the practice have been before us a number of times. My concern was I don't believe, Dr. Ho, you really answered the questions. And I'm not saying there's a violation either, but pardon me, I have a cold I'm trying to work through. With all these doctors here, it doesn't do much good.
Is there a doctor in the house?
Yeah, but that's why I was looking for an investigative hearing. There were enough questions raised in my mind where I'd like to get some answers that I don't think were in the response.
And I looked at it too, Dr. Ho, and I had some questions too. I think that I've read all the stuff, that the supplements that you've sent forth, and I think you have some good points too, but I think it would deserve to have a hearing only from the fact that I'd like to hear all the points of what's going on and so forth. Go ahead, Dr. Ho.
I think that there were questions raised in the medical consultant's report, and that is almost to the level of an investigative hearing because charts were subpoenaed. He specifically looked at 12 charts that he raised questions. The original background of the complaint, as you know, is from, the source of it, and there were maybe even more allegations in that. Most of them were all addressed by the medical consultant and dismissed even in his assessment. The questions that he did seem to raise is in 4 questionable charts, where his specific words were no actual pathology was found during these endoscopies, and then his question was whether these hiatal hernia repairs were necessary. So I think that in terms of these first 3 charts that he had unfavorable responses, part of my reply was that in terms of looking at endoscopies, he's basing it that 100% of all hiatal hernias are found at endoscopies. And that's not correct because about a quarter of these are missed on endoscopies. So I think that I addressed that. The next question would be that if he said, well, it wasn't necessary to fix them at the time of surgery, even if you see it. Again, it is clinical guidelines by American Society of Metabolic and Bariatric Surgeon and also in the International Sleeve Gastrectomy Expert Panel that the consensus is, hey, if you are in surgery for bariatric surgery, you should examine for a hiatal hernia. And if you see it, you should fix it. So I think that when he reviewed those charts for the patient MMTS and KC, he raised those 2 questions that made it sound that it's an unethical thing that I did. A, he said pathology was found. 2, he said it was unnecessary. And that's why I think my response in terms of these charts that were reviewed is reasonable. The next one that may raise questions, if you had any, and I wanted to address that, because when you think about the concept of morbid obesity, reflux, and hiatal hernia, it seems maybe is very straightforward. You want a specific response from me to say, hey, why is this not simple? And there's lots of articles, and I don't want to flood you with all the articles that looks at specifically reflux after the sleeve, which is the appropriate surgery for reflux in the morbidly obese patients. So I'm just going to summarize that hiatal hernias are associated with reflux. The sleeve is associated with reflux. We're fixated with reflux because it can cause esophagitis, Barrett's esophagus, esophageal adenocarcinoma. Even when I discuss it with patients, I ask them the questions because it's not just the discomfort of the patient that they describe. And sometimes they go to the ER with chest pain. They think that it hurts so bad they're having a heart attack. Even if I look past that, the consequences of untreated reflux is maybe cancer, potentially lethal.
Interrupt for 1 second, and maybe it's a gene question more than anything else. If we had if we were really completely informal, had no statute and had no rules, and we could do whatever we want, we could maybe resolve this. But it's a case review, and I think what you're saying is very appropriate and legitimate to talk about, but I think it needs to be talked about in the context of an investigative hearing, or are we okay continuing with Dr. Ho's comments?
I would, I do think that this type of information provided by the respondent is more appropriate for an investigative hearing.
Yeah. I'm sorry, go ahead.
Unless the board has, heard enough and changes their mind that perhaps an investigative hearing is not necessary.
Okay. Is there anything, Steve, that you wanted to say briefly?
I was hoping
I know.
And so what happens is we prepare and we come down here for the case review. So, I know what I'm losing, and I think it's futile for me to.
Okay. We can ask questions though, and she can.
Well, you know what? I'd rather save it for investigative hearing. I really would. This was just a review, just to see how board members felt if we wanted to move this forward. I do think there's enough questions here from board members that I think that we should move it forward. Okay. And I appreciate your response, Doctor. I really do. You clearly know what you're doing, okay? So please let us do that in that form so you can have a full voice, okay?
Okay.
And we want to hear the rest of the response.
We want to hear the whole thing.
Thank you.
All right. So does anybody have any other question before we vote? Can I have a motion then?
Motion to proceed to investigative hearing.
Motion. Can I have it from Dr. Madam? I have a motion. Can I have a second?
Second.
Second from Dr. Erbstrasser. Any question before we vote? All signify by saying aye.
Aye.
All opposed, same sign.
Nay.
Thank you for coming down, and I don't look at this as a waste at all. It was very informative to me just to even hear the little bit that you had.
That's
Okay?
exactly what we want to hear. That's perfect.
Will you have specific questions before that submitted to me so that I can, or?
We'll let you talk to the executive director, okay?
And Steve
All right.
knows.
Thank you, guys.
He knows what we're going to ask.
All right. Drive careful back. Have a good afternoon, you guys.
Thank you.
All right. All right. Next case. Next case is BDO-19-0015A. Brian David Friedman, DO, license number 00611. Dr. Friedman, do you want to come forward, please?
Friedman is signed in to speak along with his attorney, Mr. Myers, and we do have the patient DA
And we have the patient
present.
here as well. Okay, good.
No, there's no patient.
There's no patient. Yeah. This is about advertising
Yeah, this was
on the web.
advertising. That's what I thought. All right. And we know Mr. Myers already. Let me go here to, who were the three reviewers again?
Marty did one.
So, Dr. Reese, he is not here. He said investigative hearing.
You had a question,
And
Dr. Erbstrasser?
Dr. Erbstrasser, did you have a question? You had investigative hearing. And
I don't think this warrants investigative hearing, but I wanted to hear from Dr. Friedman what he's done since this allegation. I know you've changed your website saying that you're an ENT, facial plastic surgeon, and not a plastic surgeon. Is that correct?
Correct, Dr. Erbstrasser. Thank you, members of the board. Good morning.
Good morning.
If I may quickly, I'd like to apologize for any confusions my website may have caused. This is not my intentions. I am an ear, nose, and throat facial plastic cosmetic surgeon My board certifications are displayed proudly across my website. In the several areas where it read ENT plastic surgery as opposed to ENT facial plastic cosmetic surgery, immediately being brought to my attention by this board, it was changed.
Had you not had a chance, I was just curious, had you not seen that website before, or is that what the issue was, or did you have I know we have people that do our websites, but man, I go through those and scrutinize and look at everything on there.
Dr. Cunningham, in these two areas, it was overlooked. Rest assured, since this, before anything gets put on that website, I review it personally. The reason plastic surgery is displayed, or that word is used on my website, is because I spent 5 years in osteopathic residency, dual accredited in ENT facial plastics, and I do in fact perform plastic surgeries of the head and neck. It was in no way means to misconstrue the public or confuse them. I apologize for any confusions it may have caused.
Any questions from other board members?
I have one.
Go ahead, Mr. Nanda.
The risk of, I want to be careful, I don't run in the same situation we did on the last case, to get into investigative hearing, and we might need to do that, at least from my standpoint. The allegation was that you described yourself as a plastic surgeon on the website before you corrected it. Who ordered whom to put those words on the website?
Mr. Landau, I accept full responsibility. I am the captain of this ship. However, I did not ask them to put that. When I put this information into this website, I was very specific. It lacks no ambiguity. My board certifications are proudly displayed on this website. It was overlooked. I apologize. And those two areas of a 20-page landing were changed immediately.
Yeah, I'm not sure. Yeah, I'm not sure I'm following. The website contained the description that you were a plastic surgeon. Who decided to put that term on the website? Whose decision was it to say, okay, Dr. Friedman is a plastic surgeon?
Mr. Landau, this was done by the website designer. However, I want to take ownership of it, as this is my practice. I am, in fact, a facial plastic surgeon and graduated from a residency accredited in it.
Yeah,
the focus should be on the website.
Yeah, and I appreciate that you're taking ownership for it. But the website, how would the website designer know, or why would he use the words plastic surgeon? Was he making an assumption, or did you tell him to put plastic surgeon on the website?
I think that this was an assumption because I am, in fact, a facial plastic surgeon, and it read ENT plastic surgeon as opposed to ENT facial plastic cosmetic surgeon. Maybe he took liberties to make it fit, but this is only speculating.
Yeah, that's what I wanted to get into.
Any other questions from board members? Do you have any feeling one way or the other, or do you want to make a motion?
Motion to dismiss.
So I have a motion from Dr. Speakinman to dismiss. Can I have a second?
A second.
So I have a second from Dr. Madam. Any discussion before we vote?
I just agree that it certainly is your responsibility. I'm not convinced it raises the level of investigative hearing, but it is your issue.
Yes, sir.
And I would agree with Dr. Madam. I think that you said you're the captain of the ship. This is your, business, and this is your being a physician, that you need to scrutinize every single word, even your business cards, all of those things. That because you're out there to the public doesn't know, and so they think you're misrepresenting one way or the other. I don't think that was the case here, and I would support a dismissal. Any other discussion before we? Okay. All in favor signify by saying aye.
Aye.
All right. All opposed?
No.
I have one nay from Mr. Landau. Your case is dismissed, sir. Okay. All right.
I think I was pretty eloquent.
Okay.
Good job.
Thank you,
Good job, Mr. Myers.
Mr. Myers?
You've done a great job today.
Are you done with us today? Oh, of course not.
All right. Next case is DO-18-0164A. Stephen Brian Wallach, DO, license number 2113. Is Dr. Wallach here?
Dr. Wallach is not signed in to speak, but we have the patient,
Patient is
SA.
here. All right. So, I believe this is, so this was, Dr. Reese is dismissal. Case review was Dr. Erbstrasser.
Jeff or Mr. Brooks.
Mr.
Wanted to hear it, so I'll be good. Okay.
And Mr. Brooks had investigative hearing. So the doctor isn't here. How do other board members feel when they looked at this case?
I think we need to bring it to investigative hearing.
I would agree. When I looked at this case, I appreciate the complainant is here. Is the complainant here? I'm sorry, what are the initials of the complainant?
SA.
SA. Is SA here?
It's him right here.
Yes.
Behind the pillar.
There he is. Okay. Thank you for coming, sir. But just 1 minute, okay? I don't think we need to hear from him if we're ready to move to investigative hearing. Can I have a motion?
So moved.
So motion for investigative hearing with Dr. Madam.
Second.
Second with Mr. Burge. All in favor signify by saying aye.
Aye.
All opposed, same sign. Sir, we're going to move this to an investigative hearing, and so we'll notify you when we're going to do that, okay? And the doctor will be here, and then if you would come back, that would be great help. Thank you, sir. Thank you for coming down this morning.
Thank you.
All right. All right. Let me get back to my computer here again. Next is DDO-19-0018A, Alan John Sheen, DO license number 007190. Is Dr. Sheen here? Doctor, can you have a seat right there? Welcome. All right. Again, this is where we're just looking to see if we're going to move to investigative hearing. Welcome this morning.
Good morning, and thank you.
All right. Any questions for board members? Or
We need to move this to an investigative hearing.
I would agree with that. Any other? So, Doctor, this is just that because it was in the case review form, looking to see if we would move it to investigative hearing. So we're not in the right forum to have you speak to us yet or to testify and those things.
Correct.
But we're going to vote on if we should go forward, and I think that's what the majority of the board feels. So if I can have a motion.
Also move.
From Mr. Landau has made the motion. Can I have a second? Second from Dr. Madam. All in favor signify by saying aye.
Aye.
All opposed, same sign. Doctor, we will notify you when to be here. We will set this hopefully in probably
October.
Okay, we'll probably see you in October.
Thank you very
for
much.
coming.
Thank you.
I appreciate you showing up.
Yeah, thank you for coming.
Thanks.
Thank you.
All right. All right. How's everyone doing? Do you want a break? 5-minute break?
Yeah.
That'd be great.
Everybody? Okay. So we're going to take a 5-minute break. We'll be right back. All right, we're back in session. The next is 7. This is discussion and review of action on investigative hearings. So this will be the next part of our session today. So the first one is ADO-18-0180A, Andrea Lynn Raby, DO, license number 3508. Dr. Raby, could you come forward, please?
Dr. Raby is present with her attorney, Dr. Charles
There,
Carr.
Doctor, welcome. All right. Maybe you can introduce your attorney there with you as well.
This is Mr. Charlie Hover.
Welcome. Welcome.
Morning. Morning.
Can you swear in Dr. Raby for us, please?
Yes, I do.
Okay. And then because some of us are hard of hearing, if you can talk directly into the microphone, and then because we're recording this as well, and we appreciate if you could do that for us. I think this is Dr. Pross, is that correct? If you can review this case for us.
This case was reviewed by a board-certified psychiatrist, too. The patient, a 50-year-old male, complained that he developed or had seizures after lowering Xanax in too rapidly of a fashion. We did have this case reviewed by an outside consultant, and some of her concerns were that the patient was not diagnosed with benzodiazepine use disorder, yet the taper was not optional for the member and was completed at a pace faster than standard of care. She felt that this contributed to the seizure disorder along with the patient's methamphetamine use. She noted that there were multiple treatment options for anxiety. However, none of these options were discussed, and the member or patient was not offered. There were no other options offered to him other than Prozac. The patient was not monitored for withdrawal symptoms, but rather prescribed an anti-epileptic after a documented seizure. She noted that the taper is recommended at 10% per week, yet the patient was given decreases far exceeding this recommended decrease. She noted that the initial decrease from 2 milligrams TID to 2 milligrams BID is a 1/3 reduction. 2 milligrams BID to 1 milligram AM and 2 milligram HS is a 1/4 reduction. Each of these was not done with recommended follow-up to evaluate for withdrawal and for return of anxiety, both of which would be reasons to return to the prior dose and slow the titration schedule. Depakote was prescribed for seizure prevention without evaluation of the patient, review of full medication list, consultation with neurology, or full informed consent.
Okay. Thank you, Dr. Prom. Dr. Raby, you've heard our brief review. Would you care to comment, please?
Yes, and thank you for having me today. I appreciate the opportunity to
talk
explain.
straight in.
Thank you for having me here today. I appreciate the opportunity to be here and to explain. There are many of those statements, as you noted, that I would like to answer and speak to. This is a patient that I did see, and I did talk to my physician's assistant about, who saw the patient multiple times, and we felt that the care was both appropriate and clinically sound in regards to the medications, the tapering, in addition to different treatment modalities that were offered to the patient.
Questions from board members?
Yeah, I'd like to get some more detail as why there's a difference of opinion as to whether the care was appropriate. And clearly the medical consultant believes it was not. The patient believes it was not. Why do you believe it was?
Well, there was a difference in opinion in regards to what the medical consultant said. She had noted that the taper was too rapid, but in supertherapeutic dosing, it was actually an appropriate tapering. In supertherapeutic dosing,
or tapering, if the Xanax, for example, as this patient was on, 4 milligrams or above, we can actually go down anywhere between 25 to 30%, which was the case with this patient. We had decreased him from 6 milligrams a day, 2 milligrams 3 times daily, to 4 milligrams, 2 milligrams twice a day. And so that, by definition, is more of a super therapeutic taper, which would be in the range of the 25, roughly 30-ish%.
May I ask why such an aggressive taper was required?
So the taper was required in that the patient came in via his PCP, and we were very concerned in regards to the opiates that he had been taking as well for his chronic pain. And so we were very worried from a risk-benefit ratio that this individual would be at grave risk for lethality or decreased respirations with the combination of the opiates as well as the benzodiazepines, especially at the high dose of the benzodiazepines.
That's the answer I want to hear, but was there an event that made it critical at that time to start that wean aggressively?
I don't recall an event per se, but just with my experience of doing this, I don't know if an event has to trigger that necessarily versus just the patient, unfortunately, having medical issues in relationship to both concurrent uses of the benzodiazepines as well as the Xanax. And in addition to that, I believe he was on Ambien for sleep too.
Absolutely. No, I agree. That's a very dangerous combination. However, do I remember correctly, the patient was on Xanax for 5 years, or on Xanax at that dose for 5 years?
My understanding is he was on Xanax for 5 years by his primary care physician, and that is why he came to us.
And there was a difference of opinion between the patient and you and your PA, Kristen?
A difference of opinion between
as to the patient and you as to the amount of Xanax to be prescribed?
Yes, sir. I think that there was one thing that I've learned from this truly is that I think there was a difference in opinion in terms of the treatment plan from the beginning. And I think that in retrospect, communication is key, and I believe that he did not want to necessarily get off of this Xanax dose. And having known that, I think, have established rapport and maybe assisting him with other treatment modalities or referrals would have been important.
And that was one of, if I remember correctly, that was one of the issues with medical consultant was the lack of, or at least perceived lack of communication and meeting of the minds between you and the patient.
Although I would like to say that I did feel that in looking and remembering in treating the patient with my physician's assistant, we did meet with him quite frequently or attempt to every 2 weeks in order to make sure, rather than the every month or so, to make sure that the tapering was adequate and that he was sustaining that, if you will.
Mm-hmm. So, Doctor, you felt that with all the things going on right now with Ambien, with opioids, with Valium, this is one of those situations where there is some fear. If he were to die of this, you'd be in front of us if he died of respiratory failure, right?
Correct. And although I did only see him one time, I did care very much about him because I knew that he had many things going on in regards to other comorbidities. Mm-hmm. And I felt that it was something that we truly needed to address in order to ensure his safety.
Sure. And also I'm looking in here that it said that I won't necessarily with this situation, but how do you deal with patients with substance abuse, methamphetamine? How does that, so if you go on a binge of methamphetamine and now you're also on high-dose Valium, Ambien, all of those types of medications, and they have those large volumes at home, what is your concern there?
My concern with using methamphetamine is that it certainly can lower the seizure threshold,
okay.
And that could be an issue with precipitating a seizure. Of course, even in the most controlled environments, there's always a risk of seizures with any type of benzodiazepine taper, but certainly this could have potentially lowered his seizure threshold.
So it's theoretically possible that he could have had a seizure because of methamphetamine abuse, not necessarily the benzodiazepine taper?
That is my opinion as well, yes.
Okay.
Did he not, I know you put him on a restricted his dose, and it appeared to me that the patient, and if I remind me if I'm remembering this correctly, is that he would went ahead and still took the doses he was used to taking, and he ran out of meds at his Xanax. Is that correct?
I believe at one point he had actually gone down on his Xanax. We had wanted him to stay on 2 milligrams twice a day. I believe he went down to 1 milligram and 2 milligrams, 1 in the morning and 2 in the afternoon. And yes, at one point he had begun to run out of medications, but we had asked him to come back in 7 or 8 days in order to reassess how he was doing versus even a 2-week time period.
Okay.
Didn't he say that he continued to take the higher dosage because he was afraid he was going to have another seizure?
I believe he had been taking higher doses when he had gone to the ED, to the ER, to county hospital, and they had given him 2 milligrams twice a day at that point in June after this occurred. And he actually at that time through our clinic was prescribed 3 milligrams daily instead of 4 milligrams daily.
And just a note for our non-medical colleagues, benzodiazepine withdrawal, such as the Xanax, is one of the most dangerous toxidromes that I deal with. It's a very difficult seizure to break with a high morbidity and mortality.
Thank you.
Okay.
However, I highly commend the doctor, Dr. Rabi, for your concern because polypharmacy is also very dangerous. You're between a rock and a hard place on that.
Thank you.
Yeah. Is the any other questions to the doctor?
Counsel have anything to add?
No, sir. Thank you. I will follow Mr. Myers' example.
Very good job.
Is the complaint here?
No, sir.
The complaint isn't here. So, when I looked at this case, very difficult, extremely difficult. You get dealing with a guy that has polysubstance abuse, and then you're trying to get him off of Xanax. Even in our practice, when we have patients that come from other physicians, they're on high-dose Xanax. I'm not a psychiatrist, primary care. Usually, I will tell you, I do taper probably slower than what you had done, but I consider you to be the expert, so I would have deferred to you. My other question is that do you ever detox these patients, ever put them in, and would this guy have been a candidate for this because he was on so many substances?
Yes. Thank you very much for noting that. Absolutely. I've done detox inpatient facilities for years. I still do. And I recognized, in my opinion, that he could have gone to inpatient for detox. Unfortunately, though, that was presented, he declined.
Okay.
And I will take full accountability for that not being in the record. I want you to know that. There was no documentation of him declining of that, but I do recall in my consultation recommending that to him. Unfortunately, in the state of Arizona, we are unable to involuntarily petition somebody on a petition, court-ordered evaluation, for substance use disorder unless they're in acute danger to self or others. And so he declining that, I did not have any acute DTS or DTO, meaning a plan to harm himself or anybody else. And so having said that, I could not send him into an inpatient facility in order to detox him within a 5-day period, which is usually the case for detox.
Cool. All right. Any other questions from board members?
No, I do disagree with your taper pattern because I think that's a very aggressive danger, and if there was an immediate danger, then I would certainly raise the threshold for doing that. However, that being said, with the substance abuse history and the polypharmacy, I understand where you are, and in light of that, would like to make a motion for executive dismissal.
So I have a motion for dismissal from Dr. Madam. Can I have a second?
Second
from Dr. Speakerman. Before we vote, is there any discussion?
One comment, if I could make.
Go ahead and make a comment.
Please, in the future, because this is if you would have had that in the chart that said I wanted to admit him and he didn't. I mean, I believe you. That's not what I'm saying, and we believe you. I mean, there's no reason that we shouldn't. It's just nice. Then you wouldn't be in front of us. So for the medical students, for this, she wouldn't have to spend the money, do all this stuff if we would have had something in documentation.
And had a sleepless night, I'm sure.
Yeah. So it would have said, tried to admit the guy. We would have been like, okay. So.
And Mr. Holborn sitting next to her saying nothing is very expensive.
But it does get me away from moving 5 tons of river rock.
Dr. Raby, you wanted to say one other thing before we vote?
I would just like to say that I have learned a lot from this, and I believe as physicians, no matter what specialty we're in, we continue to learn and grow, and that is what I feel it can greatly impact patient care in a positive way. Having said that, I also want to let you all know that I have trained, I've talked to my site administrators and as well as my COO, where I currently am employed, and we have been training our staff as we speak, in regards to appropriate documentation and why. So we did have an in-service on that, and I will continue to do that.
Great.
Thank you.
Thank you.
I have a motion. Can I have a roll call, please?
Yes. Mr. Berg? Aye. Dr. Spiekerman?
Aye.
Dr. Madem?
Aye.
Mr. Landau?
Aye.
Dr. Herbstrasser?
Yes.
Dr. Cunningham?
Yes. Thank you.
Thank you.
Good luck.
Thank you.
Safe travels back. You had an excellent attorney, by the way.
He was fantastic.
Really.
Good job.
All right.
Steve, you could learn something.
All right. B is, we're going to the next case, B, DO-18-0141A. Brian David Friedman, DO, license number 00611. And I think we're going to call these two cases together. The next case also as well is C, DO-18-0113A. Again, Brian David Friedman, DO, license number 00611.
Dr. Cunningham, for the record, patient DA and BH are present for both cases.
Okay, great. So we'll go ahead and, if you'll swear in Dr. Friedman, please.
Yes, I do.
Welcome. And then I did not do this with our previous physician, just for med students. Dr. Friedman, can you tell us about your training and the type of practice that you have now?
My pleasure. I am an ear, nose, and throat facial plastic cosmetic surgeon. I have a practice both in Payson, Arizona, as well as Scottsdale, Arizona. I graduated a residency through Barnabas Medical Center in NICOM in ENT facial plastics, then went on to do a fellowship training in cosmetic surgery through the American Board of Cosmetic Surgery, American Academy of Cosmetic Surgery, and then went on to help found an additional board known as the American Board of Facial Cosmetic Surgery. I moved to Arizona in 2013 and have been practicing here since.
And yes, Mr. Myers.
Excuse me. After the presentation by staff, the doctor and I have presentations on both cases. And are we going to take both cases at the same time, or just?
I think would that be you want to just do it separate? Yeah, we'll do it.
Yeah.
Factually, yeah. Yeah, we'll do it separate. Yeah. Yeah. We'll start with the first one, but we're just going to hear them together, though. Go ahead, Dr.
Okay.
Cron, for the first case.
The complainant in this case is patient DA, and the complainant states that he was seen by Dr. Friedman for a second opinion because he was considering a septoplasty. He states that he was billed for a nasal endoscopy, and he states that he did not have a nasal endoscopy performed when he was in the office. He also he obtained his medical records, and he found many incorrect entries. He stated that his past surgical history, his immunization history, social history, medication, and vital signs were all incorrect, in that his blood pressure was not taken, his height was documented incorrectly, and his weight was also documented incorrectly. So this was actually seen or heard before the board previously at investigative hearing. The board was particularly concerned about whether a nasal endoscopy had been done, and did he bill for charged for services that were not rendered. They were also very concerned because Dr. Friedman had documented a full physical exam for every office visit, and then admitted that he had not actually performed a full physical exam. The board asked that staff perform a chart review. So I did ask for 10 medical records, and I found that in the chart review that a complete review of systems and a complete physical exam was performed or documented in almost every case. And that included people that were just seen for allergies and things like that. So it does seem that he has an EMR that auto-populates, and I think that it just shows that that's typically.
Dr. Pearl, was that also, I didn't see, was that including like genital exam, allergies, endo? Do you remember?
No, it didn't go into that, but it was,
abdomen,
heart and lungs, abdomen.
Okay. Cardiovascular.
Got it, thanks.
Yeah. And a complete review of systems, things like that.
Thank you.
Okay. Dr. Freeman, go ahead.
Thank you, members of the board, for allowing me to come back and respond. Months have passed since
Good, thank you.
Months have passed since our initial meeting in this matter, along with tremendous amounts of internal reflection, and all that's transpired since. I sincerely took to heart the very appropriate board's review of my medical records and practice. So many wonderful things have happened in my life since our initial meeting. The birth of my son, the most magical. The opportunity to raise my son righteously and with virtues. I know no greater joy. Much like my son, I built this practice from the ground up. And when anything is brought to my attention to suggest it's less than perfect, the initial defensivity once let go, I embrace it and look as in an effort to improve and make improvements in my practice, much like rearing a child. And since the board's initial evaluation of this matter, I would really like to share with you how I've improved and highlight a few of those aspects. With regards to the entry of vital signs and height and weight, me and my staff as a team have made strong efforts to improve. We've updated our intake patient forms to be more inclusive and more accurate and more descriptive. An updated version was provided. In addition, we now have monitors as opposed to just subjective assessments of heights and weights. We actually take them. I think this is an excellent means of improving patient care as well as a more complete chart. It's made for an improved patient experience all around. The second aspect of the board's initial inquiry was with respect to obtaining a consent for a nasal endoscopy. Certainly a consent form serves as another form of proof that something was done, but more importantly for informed decision making. I pay great attention to informed consents when it pertains to surgeries and invasive procedures as risks. The board agreed that no informed consent was necessary in this matter. The next point involved charting and templated notes. In my note-taking, I openly admitted the notes auto-populate. However, with regards to the ENT aspect of my exams, these are done line by line, individual clicks made that are tailored to that patient. The other systems in the past, I did not review. When this was brought to my attention by Mr. Landau, that day after that initial hearing, I went in and changed these things to more accurately reflect what was done. If a system was not examined, it auto-populated as not examined or not auscultated. For new patients moving forward, I assure the members of this board this will never happen again. And those patients that are established, daily I go into their charts when evaluated to correct the inaccuracies. I was a tremendous fan of paper charts, diagrams, pens and papers, something tangible to interact with the patient. However, electronic medical records are here to stay, and I am slowly yet progressively learning the ins and outs of my own. I welcome the opportunity to grow in this matter. I owe it to myself, the patients, and our profession. With the goal of improving on my chart taking and my medical records, I have signed up to attend a 3-day intensive PACE course in October. Rest assured I am driven internally to approve. I truly hope the board recognizes the efforts I have made to improve on areas that need attention. This case has been hanging over my head like a black cloud. As mentioned earlier, wonderful things, beautiful things are blossoming in my life. And to have this intertwined in my heart is hurting me. I take it to bed every night. It has taken zest out of my daily routine. The last item that I want to address is the one that really hits home the hardest to me, doctors and members of the board. It has to do with billing for a procedure that was not done. I am upfront and honest in the areas that my practice needs attention, and I am open to improving. However, one such area where I must hold firm on is my integrity. The elements and finding of that nasal endoscopy were entered manually, all 20 clicks or so. I entered it because it was performed. I recognize DA notes that previous ENTs performed endoscopies and mine was not done. Perhaps reasoning may be more painful or more memorable. However, that does not suggest such an exam was not conducted. The nasal endoscopy was done specifically to give the best possible medical advice and had nothing to do with upcharging this patient. In addition to my testimony and what I've stated in letters to the board, I included a letter from a practicing otolaryngologist in strong agreement that a nasal endoscopy is customary when evaluating sinus anatomy, especially in a patient seeking a second opinion on traditional versus in-office sinus procedures. I truly hope the board recognizes and appreciates my efforts to improve this practice. I ask the board to truly believe in me when I say I am in this for the love and joy and peace it brings to me. I hope you can embrace some of the energy I demonstrate today and my passion for what I do and look past this as an isolated incident. Thank you.
Steve.
Mr. Chairman, members of the board, patient DA is convinced that Dr. Friedman did not perform an endoscopy. And I believe he's sincere in that regard. In my own experience, however, I have been certain that I had or had not said something or had not done something, only to have a credible colleague advise me that my memory was wrong. That actually happened to me in my very first Superior Court trial case. The first 90% of the patient's complaint addresses his medical record and all the tests recorded and information in the medical record that he believes did not occur or were in fact incorrectly entered by Dr. Friedman's staff or attributable to a template. If the patient believed or perceived that so many entries were incorrect, I believe the greater likelihood that he might believe that an endoscopy had also not been performed. In his testimony before board members at the case review, patient DA volunteered to the board members that, quote, I probably was there for 45 minutes to an hour. He did not state, as most patients do in these circumstances, that he waited for some period of time in the reception room or indicated the amount of time in the reception room. DA was a new patient. Consistent with DA's testimony, Dr. Friedman testified to the board members as to the length of time he spent with DA. He said, quote, I like to spend on 99 204s, a new patient, 30 to 40 minutes. According to the medical literature I reviewed, the period of time necessary to perform an endoscopy takes only 1 to 2 minutes. Dr. Friedman has advised me that he's much, much faster and performs an endoscopy in seconds. Thus, there was plenty of time for him to have reviewed the patient's history, perform a focused examination, and to have performed an endoscopy. While Dr. Friedman's medical record needed vast improvement, for which he has made immediate and substantial corrections to his template, I believe that DA may not be credible. In his complaint, DA states, for example, that Dr. Friedman's medical records is false in stating that he had not had previous surgery. In his complaint, he stated that he had surgery, but in his intake, he stated twice that he had no surgery. Most importantly, I believe it's simply not credible that Dr. Friedman did not perform an endoscopy. DA states in his complaint that another ENT had obtained a diagnostic image on April 4, 2018, and he was seen by Dr. Friedman for a second opinion on June 28, 2018, which is almost 3 months later after the earlier office visit with an ENT. I believe it would be extremely imprudent for any ENT not to have performed a follow-up endoscopy, and I can't believe that any responsible ENT would have done so. The anatomy of a human can and does often change in a 3-month period of time. I have represented ENTs before this board who have performed an endoscopy of the sinuses in which cancer is not apparent and then unfortunately is apparent as soon as 2 months later. Should that have, for example, or some other circumstance have been the case and Dr. Friedman had not performed an endoscopy, that would be an easy plaintiff's malpractice claim and also grounds for this board to have considered disciplinary action. I do not believe that any responsible ENT would not have performed an endoscopy in these circumstances for this patient. It's not credible that it was not performed in an office visit. The patient state was 45 minutes to an hour, and Dr. Friedman testifies similarly. The allegations are also not credible if you've had time to read the letter provided to you by Robert Mignoni, DO, an ENT for whom Dr. Friedman was chief resident. In one part of his letter, the doctor states, Dr. Friedman has a benevolence and humanity that is second to none. We had a patient in our service that no one seemed to be able to treat. This patient had bounced from hospital to hospital. The list of consultants was endless, and most notes seemed to be giant question marks. Dr. Friedman worked tirelessly to make the patient feel taken care of and comfortable. He would visit the patient multiple times a day, read textbooks about how he could help with his care, and he even did the most basic things to see that he was comfortable, such as getting him a warm blanket. To this day, I have yet to meet a more caring physician who went beyond his means to help those around him, end quote. This letter describes both a diligent and a caring physician. Thank you.
All right, thank you.
I got a question.
Question, Dr. Erbstrasser, go ahead.
So, Dr. Friedman, can you describe for everybody here, how do you do a nasal endoscopy?
And you have to use the microphone, and I'll get out of the way.
Utilizing a rigid scope roughly 10 to 15 centimeters in diameter, I'll put it into each nostril to assess what I call the osteomeatal complices, or the main traffic entry points of the sinuses. With a brief few moments of time, I can assess if the procedure that he was actually coming to see is feasible and in an office versus surgical setting.
Right. Length, I hope, not diameter?
The diameter of the scope ranges between 4 and 2 millimeters.
Thank you.
No problem.
And 15 centimeters.
10 to 15 centimeters, yes, in length.
I would think one would remember that if it was up their nose.
Yes, I do. I agree with you.
Go ahead, Dr. Speakerman.
You said that you do, and we all understand the limitations of autopopulation, but you said in your testimony that you do chart individually on the ENT portion, so clicks and stuff like that. Do you chart in the room with the patient? Because if you were there for 45 minutes, when I'm in the room, I try to chart in the room so I can remember before I go on to the next patient.
Sometimes yes, sometimes no. I have a tendency, doctor, when I'm doing the charting in the room to show the patient my back, and it breaks that continuity of eye contact.
Oh, I'm just asking in the sense that because if you do it in the room with the patient, especially that ENT component, or you do the scope and you do it right there, then you know that's the patient. I've done it on that because there's an opportunity to think that if you see how many patients do you see in a day?
I would suggest on a routine day, 15 patients.
Oh, so it wouldn't be, remembering those patients isn't that hard to do.
This patient I had good recollect from because he had come from another doctor, a very credible skull-based surgeon, fellowship trained in rhinology. So my attention was on for this patient because now I'm not competing, but I'm giving opinions based on also someone fellowship trained in rhinology. So I really wanted to come correct for this patient because he was coming to me for a second opinion, trying to avoid a surgery.
So when somebody comes to you for a second opinion, like you just testified, has there ever been an instance where you forgot to do a nasal endoscopy, to your knowledge?
I am certain that there are times where I've forgotten to do things, doctor. However, as it pertains to the nasal endoscopy performed here, each aspect was individually charted, so I had to make these clicks on the auto-populated note in this area to know it was done.
Okay. Thank you.
Mr. Landau? Mr. Berg?
No, at this point I don't have any questions.
Berg, you have any questions?
No.
I went a little bit later, but
And just a little bit for educational reasons, it's
Sure.
such a problem. I'm sorry, Dr. Friedman, this is also partly for the medical students.
It's no problem,
benefit.
doctor.
This is a little bit of an epidemic, and it's not new for electronic medical records. It's something we used to do by hand. Electronic medical records just makes it easier to create a problem. But our charts are ours. We're responsible for our charts. If I document that a patient's heart rate and rhythm are regular, or the patient has no murmur, or the patient is a certain weight, and I don't expect you to weigh your patients too. I know that there's some things you have to rely on your staff to do, but the final chart is still yours. If I get this patient 2-3 weeks later, and I pull the chart and I see there's a 10-pound weight difference, possibly a gain, and I'm concerned about congestive heart failure, and I listen to their heart and there's a murmur, but it was just documented they didn't, I have to worry about something acute coronary that occurred with this year. And it's something that could easily lead to unnecessary testing. Also, and I don't know your billing practices, but a full physical examination can raise a chart to a different billing level and can create an overbilling situation for patients too. And again, I don't know what your billing practices are, but if you chart that, you can claim a higher billing rate consistently too. And if you're not doing the work, obviously it's unethical to bill for it. I'm sorry to expand.
I'm glad you went through that. Before we bring up the complainant, my question is that what have you done now to correct your EMR records now?
As it pertains to correcting the EMR records, the first thing I did is start by improving on the paper chart itself, the intake form that the patient fills out, surgical history, medicines, medications, anything and everything that if something were happened, I got called out of a room, I needed something to reference, I have some hardcore evidence there. As it pertains to the charts themselves, I have eliminated all templates. Much like when the power's out and you go to the bathroom and you go to flip the light switch on, you're like, the power's out. It was such a routine to auto-populate. I needed to eliminate that. So now each of these areas, when the notes auto-populate as it pertains to not ENT, it says not auscultated. No sign in the neck, cardiovascular, did not auscultate heart. Very clear and concise there. In order to improve efficiency on the patient's vital signs, things of this nature, now as opposed to just subjective assessments, we take them. Granted before a surgical procedure always, but now on new patients I do that routinely to just make for a good foundation of care to move forward.
Okay. I do have one question. Dr. Friedman, what is your October PACE course? Is that medical records?
It's in medical records, accurate charting. It's through PACE.
Right. Is there a PACE course on office management?
No. Not that I'm aware of. No. Not that I'm aware of.
There probably should be. Doctors and lawyers sometimes struggle in that area.
Sometimes?
I'm being benevolent.
Any other questions that I want to ask the doctor before we bring up the complainant? Okay. If you guys want to you can either stay there or you can, we'll have him come over here. DA, you want to go ahead and come forward. Welcome. Thank you for coming today. Sure, and have a seat right there. I appreciate it. Thank you. Can you swear in DA for us?
I do.
Okay. And if you can talk directly into the microphone too. You've heard the statements that we've this morning so far. You've heard the review again. I remember you came before us, and also you've heard the statements today. Do you have any comments that you'd like to, any of the comments you've heard this morning?
Yes, I do. Basically, this case is being misdirected by Mr. Friedman. My complaint initially was being billed for a service that was not performed. The medical records serve as proof of that. It's not an issue of medical records. And this is not a case of a computer template making an error or a medical assistant entering data incorrectly. The endoscopy that Mr. Friedman claims he performed had no signed consent, no lab work, no images. The only evidence of an endoscopy is Mr. Friedman's notes that state, quote, evaluation of postoperative healing, end quote. I've never had any surgery on my sinuses. So how can there be post-operative healing? Mr. Friedman not only did not perform the nasal endoscopy, but failed to gather critical patient information before making a medical recommendation. A comprehensive exam was not conducted, nor was one sought. The proof is documented in numerous and verifiably false statements. The reason that my height, weight, blood pressure, medical history, vital signs, immunology history, etc., are wildly incorrect as they were never taken. My name and age are the only factual pieces of information on the medical notes. Mr. Friedman admitted in March 16th hearing that he did not perform the cardiovascular exam. The fact is that no part of a comprehensive exam was performed. It is the only rational explanation. The evidence speaks for itself. Please do not be distracted. This is not an issue of a clerical error. At my appointment of June 28th, I discussed with Mr. Friedman options to treat my sinus condition. I agreed to undergo skin allergy testing scheduled for July 19th. On July 11th, I canceled the appointment. In early August, I received a bill for the endoscopy that was not performed. This is a clear case of taking the last bite out of the apple, adding a false charge to a bill, knowing that the patient will never return. I gained nothing by coming here to testify under oath twice. And in closing, I quote Warren Buffett, quote, "In looking for good people to hire, look for three qualities: integrity, intelligence, and energy. And if you don't have the first, the other two will kill you," end quote. I believe that standard especially applies to doctors. I humbly beseech the board to give serious consideration to the preponderance of facts presented and impose discipline on Mr. Friedman. Thank you.
Thank you. I think you had a...
I'm sorry if I'm out of line, but this is Dr. Friedman, but I agree with you, Warren Buffett is awesome.
Dr. Earthstrasser, did you have a question of the complainant?
I wanted to hear from the patient DA, and I mean, and this is a scenario we've heard the first time, the second time, and I believe him.
Okay. All right. Any questions from the...
I have a question for Dr. Friedman. From your standpoint, how is the endoscopy documented in the records, and if you could point to that in the records?
Sure, Mr. Landau. The one aspect of the nasal endoscopy referenced again is such, as it pertains to the statement he's saying, evaluation for post-surgical procedure healing, which he had not had, there was punctuations left out of that. When going through these items, one that I click was, in conjunction with an anterior rhinoscopy, a nasal endoscopy was performed for one or more of the following reasons. The last of those is evaluation of post-surgical hearing, semicolon. It is not a suggestion that he had a surgery. It's just a suggestion of that click that the reason for the nasal endoscopy included several of the following. And then one of those was post-surgical healing, how that it did not pertain to him specifically.
Let's go to the records.
Sure.
And point out to me where you indicate that an endoscopy is completed.
In the physical exam findings, it reads under nose, on a portion says nose, and then it goes through and it starts listing in the physical exam findings of the note.
I'm trying to see what page is that on.
You've got page 3 of 9 of the medical records has that nasal examination on it.
Page 3 of 9, okay. No, starting with nasal passages?
Yes. If you can read through it and you see where in conjunction with a nasal endoscopy was performed for the following reasons.
For one or more.
For one or more of the following reasons. And then it starts listing them. The last is the evaluation of post-surgical healing, semicolon, but it's all encompassing to include reasons for the nasal endoscopy.
I think that reads fine, Mr. Landau.
Okay.
DA?
Yes.
Can I ask you a couple questions? When was your last full physical?
Full physical, about a year ago.
Okay. And it was, you had a prostate exam, blood work, testicular exam, whole thing?
No.
Okay, so you would remember if you had a prostate exam?
Correct.
Would you remember if you had a testicular exam?
Correct, yes.
So are you also saying that you would remember if somebody stuck something in your nose?
Correct. And as I noted, I had that done 3 months prior by another doctor, so I did know, and I know I've been through it, so I do know.
The last rectal exam. Because you need one because you're old enough. You got to use prostate.
It's overdue.
Okay.
But I've had it, and I know it.
Okay, good.
All right. So that was my question, and I think Dr. Speakerman did an excellent job of bringing that up. You don't recall having anything put into your nose whatsoever?
I've had a nasal endoscopy by another doctor.
From Dr. Friedman?
No, but Dr. Friedman, no.
Okay. All right.
You
said you just had allergy testing. So what happened with the allergy testing?
I agreed to undergo allergy testing, then I canceled the appointment.
Okay. All right.
There was most of that appointment was a discussion of environmental effects and various other issues affecting my allergies. It was not an exam.
Okay. Any other questions from board members? All right. Thank you so much.
Thank you.
You can step back if you want.
Thank you.
All right. Dr. Friedman, do you care to make any comment?
May I ask a question?
You don't have to phrase it as a question. I would prefer that you not phrase it. I would prefer that you not ask questions from board members.
Dr. Cunningham, clearly there was elements of this note that were auto-populated, and clearly there were areas of this note that misled in terms of his medical history, which is his own, and those are my faults. I'm trying to find some commonality to explain for all of these things, and my thoughts on the matter is this: is that because of the other inaccuracies, it led to a tone of this letter of anger, and rightfully so. Some of the areas I can appreciate, but in 45 minutes with patient DA, I have a question: is for 45 minutes, which he openly admits, he came to me and said, what was I doing? I mean, every day I do this. It's my routine. He came into me for nose and sinus complaints. In 45 minutes, I wouldn't have looked in his nose. That's exactly what I would do. How else would I have given him informed decision making?
May I comment, Mr.
Go ahead.
So, although I have to say that obviously portions of the physical examination are auto-populated, and that's wrong, I also have to say the nasal passage examination is not typical for an auto-populated response. It has specifics that are variable. So this does not look like a nasal passage note that's auto-populated.
Yeah, I see that.
Dr. Prohl?
Dr. Prohl had a question.
I just wanted to clear something up. The employees put an incorrect weight and height and blood pressure. And you mentioned that now you're actually going to start taking blood pressure. So are you saying that your employees did not take his blood pressure and typically don't take the blood pressure and just write something in?
The training of my staffs prior to the board's initial hearing is such: what's your height and weight, and then they list what's given by the patient. Okay. Much like when I asked about his surgical history, he said he had none, as his own suggestions list in his own patient intake form. He himself said he didn't have surgeries, and I really wanted to spend my time showing the board and its members the means of improving and not backtracking, saying he said, she said. Clearly, the two of us have a tremendous variance of what happened that day.
Yeah, but doctor,
what about the blood pressure?
Yeah, I was going to say the answer to the question.
Sorry.
Blood pressure.
So the staff asked the patient, what is your blood pressure? And then based on their responses, what is given?
What?
Yeah, but that makes no sense. Because my blood pressure changes every 5 minutes.
Yeah.
The patient
height and weight, I could see. But blood pressure, that just makes no sense at all.
Right.
I'm just not following.
The patient asks, the person would ask the patient, what is your blood pressure? And then he would give an answer. What is your average blood pressure? Okay. It was poor. It was a poor aspect of it, and moving forward, I now have vital signs and take it myself.
Gene, I wanted to ask you a question before we move forward. Do you want us to adjudicate this case first, or do you want us to go on to the next one and hear what that one is?
I think you can determine whether violations occur in this case,
okay.
But they get the factual information from the second case.
Okay.
And if there are violations in that case, you can consolidate.
Any questions from other board members? Mr. Myers, do you have any statement?
I do not.
Okay. I would like to make a motion to go into executive session for legal advice. And can I have a second? Second. All in favor, signify by saying aye.
Aye.
We're going to be right back. We're going to go into for legal advice. Just a minute. right, we're back out of executive session for legal advice. Go ahead, Mr. Meyer. You got a statement you'd like to make?
Just 10 seconds.
Okay.
I want to clear up some confusion.
Okay.
While the scope is 15 centimeters long, it only enters the nose 2 centimeters, and as I said before, for seconds. Thank you.
Okay.
That was 10 seconds, too.
Okay.
I was counting.
Okay. Questions or statements from board members, or what would you like to do?
Just one other comment, if I can. If I remember correctly, it's tab B from the patient's reported history, where it reports the medical history none and surgical history none, and if I believe correctly, it has an attestation signed by the patient, which would certainly raise a level of confusion for the doctor. And it looks like that was dated on 6/28/2018.
All right. Okay.
Well, I guess we cut to the chase as to the exam and the billing goes with the exam, but as to the exam, I don't think there's any question as to the inaccurate medical records. I'm still puzzled and not satisfied with the answer on blood pressure. That's just, beyond me. But that aside, clearly a minimum letter of concern and CME, continuing medical education, which I will ask that we officially order on medical record documentation. So I think that's, to me, pretty obvious. The other question becomes whether or not the exam was completed. And I think there are consistencies in total, looking at all the medical records, the questionnaires, the comments, the testimony here. I think there's some consistencies and inconsistencies on both sides to the point where, quite frankly, I'm not sure. And the burden of proof or standard of proof is that there needs to be a preponderance of the evidence, in a sense more likely than not, more than 50% that the allegation was committed. And I'm just not sure, so I'm not going to go there. And so my motion is for a letter of concern for failure to maintain accurate medical records, and for failure to supervise. Others might want to go further, which is fine, but that's my motion.
So I have a motion.
I would second that, Mr. Landau.
From Mr. Landau, and then also have a second from Mr. Burge. Any discussion about any of that?
Yeah, just say that just as general for all of us. Right. It doesn't preclude any other motions, right. But just I'm focusing on this one point right now.
Okay. Yeah, as long as it doesn't preclude from anything.
Yeah. Right. Any discussion?
No.
Okay. Let's have a roll call.
I'm just.
So we're just doing on the records, okay? Nothing else.
On the records.
Yeah. We can still talk about other, okay? All right. So can I have a roll call, please?
Yes. Mr. Berg.
Yes.
Dr. Speakerman.
Yes.
Dr. Madem.
Aye.
Dr. Erbstrasser.
Yes.
Mr. Landau.
Aye.
Dr. Cunningham.
Yes. And you want to attach to that, then also, he says he's going to PACE. Do you want to make that a non-disciplinary order?
Yeah, I move for an order of non-disciplinary continuing medical education on medical records, documentation. Is there and this maybe is attached to my other question, a course or anything on supervision of staff?
I've searched for that for many, many years. Not that I'm aware of.
Okay. So on medical record and documentation.
Would he be able to satisfy that with the existing course he's taking, or would that be separate?
Yes, he could probably do that, but the thing is he hasn't done it. So,
okay.
So if he'd already done it, then we might consider it, but he hasn't. So
fair.
I want to make sure it's a board order and he has to do it.
Okay. So I have a motion from Mr. Landau. Do I have a second?
Second
from Mr. Burge. All in favor, signify by saying aye.
Aye.
Aye. Opposed, same sign.
And just to clarify, it's non-disciplinary, and is it allowed to be counted toward his renewal?
Toward his what?
His renewal
Sure,
hours.
that'd be fine. That'd be fine. Toward his renewal of his license. That'd be fine. All right. And I think then the next question is, and I think it's grappling with all of this, Doctor, is we have the statement from the complainant, and then we also have yours. So we have in the medical record that an exam was done, that we can see that was done, and then we have here that the complainant says that it was not done. So it's and it's to figure out which is one way or the other. I'm going to just tell you, it makes it difficult, I'm going to say. I think Dr. Erbstrasser has some questions or some statements he'd like to make about that. What do you feel?
Well, you can't, when you talk about the medical records, obviously there were some things that was falsified, not falsified, but wasn't recorded appropriately, accurately.
That makes it the same thing.
And then you did an exam on him, supposedly, and you have it documented, and he's had an endoscopy, nasal endoscopy, through, 2 months ago, 3 months ago. He knows what it's like, and then he's telling us that he didn't have it performed. So somebody's lying. So, and I'm trying to figure who it is. So I still have lots of questions.
Yeah, I think one thing that's not clear is that whether he had an endoscopy before as opposed to a CT scan.
No. It states that he's had a nasal scope before. He knows what they're like.
The disc that he brought, however, was to his office was for a CT scan.
Well, that's okay. I mean, he tells me he had one. Why wouldn't I believe he had one? He knows what they're like.
You want to have him come up here and just verify that? DA, would you mind just coming up here? I want to remind you, you're under oath. You're still under oath. Have you had, I just want a previous nasal endoscopy before?
Yes. April 4th, 2018.
So you understand what a nasal endoscopy is?
And I'll even kind of go into detail about it. It was April 4th of 2018. The previous doctor that I went to first, the surgeon. And actually it was so much discomfort that he gave me a bottle of water to drink after that because of the flush coming through from the endoscopy. That was the same day that the CT scan was done. I remember it vividly. It's been almost over a year ago. It was about almost 3 months before I visited Dr. Friedman.
He'd like to respond.
Go ahead,
to Dr. Friedman.
Dr. Erbstrasser, I understand where you're coming from, and clearly my medical records is doing me no favors here. DA not only suggests that a nasal endoscopy was not done, he's suggesting that there was no physical exam done. In his testimony, he suggests I did not examine him at all. To hear such a statement is to suggest like I put my right shoe on my left foot and my left shoe on my right foot. For 45 minutes, doctor, he was in my office. My nasal endoscopy correlates with the CT scan findings as well as another otolaryngologist findings suggestive of the such. I didn't make it up. I didn't pull this gentleman off the street. He came to me and I tried to give him the best informed decisions versus in-office versus a surgical procedure, which is never to be taken lightly. These things were done. I entered them in the note. I think that had this note been a little bit more accurate, as opposed to blood pressures, which was wrong to just ask the patient subjectively and not take it. It has been changed. Had all these things not propagated the patient's frustrations, rightfully so, perhaps he's not going to make the statement that no exam was done. Perhaps prior to it he would have called me and said, hey, Dr. Friedman, I had a nasal endoscopy. Did we do this? Because I don't really recall. Maybe it was a couple seconds. Could we do it again? He was angry and he came to the board and as well as his insurance company, guns blazing. Rightfully so, he's entitled to it. But Dr. Erbstrasser, it was done.
Okay. Go ahead.
I'd like to address the issue about the blood pressure. Blood pressure wasn't taken, and nor was I asked. The number given is a round number, which somebody who's better at math than myself would probably be able to tell you what the probability of two round numbers being in a number sequence, 110 over 80. If I would have been asked, the number I'd been given would be 130 over 80. Because that's an average blood pressure I'm going to be taking at a doctor's office. I would have never said 110 over whatever it was, 70 or whatever it was in the notes.
Okay.
I would not even given that number.
Okay. We've got it. We got it. Thank you so much. How do board members want to feel? How do you feel, Dr. Speakerman?
So we have to deal with the preponderance of the evidence, okay? And it's he said, she said. I believe in your heart of hearts that you believe you did it. I really do. My concern is we have omissions in the medical record that are inconsistent with what you're telling us. His estimate of it with blood pressure, with all of the other things, is always consistent. And for the medical students here as well, documentation is for your protection and preservation. Okay? So the problem of it is you're asking me to believe something when you're literally telling me, sometimes I did that and actually it auto-populated, and sometimes I didn't do it and it actually auto-populated. Now I'm changing and I'm going to see. So the problem of it is it's kind of like the boy who cried wolf. I would love to believe you. I really would. But the problem of it is if it was, beyond a reasonable doubt or something, but it's the preponderance of the evidence. And there's enough evidence here to not sway it in your favor because of your lack of documentation.
Mr. Burge, do you have any other? You'd like to make any comments?
No, I feel similar to Dr. Speakerman, but I feel like I've taken a little bit of a different tack, just in that I don't feel like there's enough information. It's a very compelling case on both sides, but I don't feel like the scale has tipped in either direction. And given that the scale has not tipped in either direction, I have a very difficult time finding the violation.
Go ahead.
An attorney once made a comment to me after a finding of not guilty on a criminal case. Not guilty verdict doesn't mean you're innocent. It means that the jury or the judge did not find beyond a reasonable doubt that you're guilty. So if there is a finding of a violation here, there is a finding that there's, by at least preponderance of the evidence, that Dr. Friedman documented the exam that was not performed. If there is not a finding of a violation, it's not a finding that Dr. Friedman did the exam and therefore documented. It's just, it could be that we just weren't sure, and as Mr. Berg said, it didn't tip the scales. So I want to differentiate between the two, which I think is very, very important. And I don't know how my colleagues are going to go on this. I guess we'll find out here in a moment.
And again, Dr. Speakerman, I'm sorry to bring this up again, but there's the patient information form, which was signed by patient DA, does also state no past medical history and no past surgical history. There's documentation problems on both sides. Okay. And I'm sorry, I know that you look at a lot of paperwork and it's easy to overlook that too, so I'm not saying that's a flaw on your part, but it does create confusion.
Sure.
Any other? Does anyone want to make a motion, or are you satisfied that we move on to the next case?
I'm satisfied.
Dr. Erbstrasser.
No.
You want to make a motion or no?
I make a motion for fraudulent charging.
So we have a motion for fraudulent charging. Can I have a second?
Second.
Well, I have a second from Dr. Speakerman.
Can you hold on one? I got kicked. I'm sorry. I got kicked off.
Okay.
Because I want to go back to the allegations.
I'm sorry, would you be comfortable expanding on the fraudulent charges?
Well, he billed for a procedure that wasn't done, though it's documented that he did it, and the patient states that it wasn't done.
Okay.
That's my question. Thank you.
Yeah.
Let me go back for a moment, if I could.
So before we vote, let's have some discussion, and then first let's get...
Yeah, I just got kicked off.
Let's tab C.
I'm looking for the...
It's one of the supplementals? Yes. It took me a long time to find it, but it's a tag when we get to the top. Sorry.
Oh, it's in there.
Yeah.
Small letter.
Somebody can
Mr. Lando, do you want to take a look on here?
No, I'm okay now.
Okay.
Yeah, I'm just looking to make sure I have the actual allegations that the doctor was noticed on, which was engaging in practice of medicine. It was 6 and 38. Is that what we have, Justin or Jean? Is that all you have?
So I saw it was on there.
I just want to make sure those are the only two. Is this the same thing? It's been there twice.
6 and 38. That's what I noticed.
6 and 30. So he was noticed on engaging in the practice of medicine in a manner that harms or may harm a patient that the board determines falls below the student's standard of care, the community standard of care. And 38. How is this?
It's now 39.
39.
They changed the number.
I don't see 39.
Yeah, 39's on there. Did those
Different
numbers
one.
change, though? It's the end
Yeah,
of
the numbers
conduct or
changed.
practice that
It used to
endangers.
be 38.
Right, I thought
and
so.
it recently changed to 39.
So committing any conduct or practice that endangers a patient's or the public health or may reasonably be
Okay.
accepted to do so.
All right.
So we did not notice him on billing for service that was not performed.
Okay,
so-
so where does that leave us then, Jean?
Excuse me?
Where does that
Probably
leave
go
us
to
then?
executive
Yes, we'll
session.
notice on it.
I'm going to move we go into executive session.
Okay. So I have a motion to go into executive session.
Second.
I have a second. All in favor, signify by saying aye. We'll be
Aye.
right back. We're back at our executive session for legal advice.
Getting a motion is
And then,
Yes,
Dr.
Dr. Cumming. Dr. Cumming, in executive session, I would like to withdraw.
You don't need to talk about the executive session.
I
You
would
just
to
need withdraw
withdraw
your
my
motion
at this time.
Right.
And I second it.
And he seconds it. Okay. Can I have a new motion?
Mr. Chairman, I move that the board find a violation of 32, 1854, 6, and 38 in that Dr. Friedman included in his medical record that he conducted an nasal endoscopy, an exam that was not in fact conducted, therefore making that a record of that such an exam part of a medical record that is a permanent record that could be used by the patient and the and future physicians, therefore resulting in harm and potential future harm to the patient and further falling below the community standard.
That's your motion. Can I have a second?
Second.
Second from Dr. Erbstrasser. Discussion before we vote. Go ahead.
Now they made the motion, I'm not going to support it, but I made it for discussion purposes for the reasons I stated. I stated previously. I think there are believable statements on from both DA and from Dr. Friedman, then some inconsistencies on both. I think both parties, and someone answered questions on both parties, and the burden is the preponderance of the evidence. And at least in my mind, I'm not saying something happened or didn't happen. I just don't see that burden being met. So I was glad to make the motion to facilitate the discussion, but I'm not going to support the motion.
Go ahead, Dr. Beadham.
My only addition is I certainly agree there are multiple inaccuracies in the chart, and that is in itself a problem. However, I have to agree with Mr. Landau on this.
Any other board members want to make any comments before we vote? And Mr. Burge, do you have I'm going to tell you that when I look at this, I'm going to tell you there's a lot of problems here. You know that. And we have a lot of things that have in your record keeping, and it even sounds like even how you ran your office. It was very disturbing too with your staff and how vitals were taken and so forth. I think DA is very believable. Yeah. I'm going to tell you, I think he is. I commend him for coming down here and telling his side of the story. I hear your side of the story too, Doctor. I really do. So there's a difference of opinion between the two. Like you said, it's he said. And so I'm going to tell you that I can't support the motion because I don't feel there's enough evidence for me to go in that direction. That being said, I think we should go ahead and vote. Go ahead.
One other thing, we, and many of you here have been here for a lot of cases, and I didn't realize until Justin told me I'm coming up on 10 years on this board. And a little more than 9, and there aren't that many cases that are this close and where you have a very definitely complainant who is believable, and then you got real questions on what happened and on what didn't happen. So. This one, we have some newer members on the board. This one's a tough one. There's no doubt about it.
And in addition to my last comment, I'm hoping this is something that you're learning from, Doctor, moving forward. So we'll take a vote and then we'll go from there. We can talk more about that. Okay. Let's have a roll call.
Mr. Berg?
No.
Dr. Speakerman?
Aye.
Dr. Madam?
No.
Dr. Erbstrasser?
Yes.
Mr. Landau?
No.
Dr. Cunningham?
No. Motion fails to pass. So we're going to move on to the next case. That being said, before we leave this case, I want to thank the complainant that came here because he was very insightful for this. And I think the doctor has learned something from being here. Clearly, you need to talk to the patient and say, we are doing a nasal endoscopy on you today, and have a consent form, whatever you need to do from now on, so that you are never put in this situation again, period. Okay? All right, let's go to the next case.
Can we have a bathroom break?
Sure. We'll give you...
What were you doing in the last 20 minutes?
Never know when you're coming back.
Okay. You have 5 minutes then, sir. Back in session. Next case, DO-18-0113A. Again, Brian David Friedman. Dr. Prock, can you review this case for us? And I'll remind you that you're still under oath, Dr. Friedman.
And Dr. Cunningham, he has a presentation after, and then I've got like 2 minutes.
2 minutes.
Absolutely.
And Mr. Landau will be timing me.
This case involves, this case was reviewed by a board-certified ear, nose, and throat surgeon. This person that reviewed the case felt that the surgery that was performed on this patient was much more extensive than would be suggested from the CT scan. This is a 35-year-old male that was taken to surgery with Dr. Friedman on the 23rd of February in 2018. He performed a septoplasty, SMR, of the inferior turbinates bilaterally. A maxillary antrostomies with removal of tissue. Bilateral frontal sinusotomies. Bilateral ethmoidectomies, total ethmoidectomies. Bilateral sphenoid sinusotomies, and bilateral concha bullosa resections. His diagnosis was a deviated septum, hypertrophy of turbinates, chronic maxillary sinusitis, chronic frontal sinusitis, chronic ethmoidal sinusitis, chronic sphenoidal sinusitis, and atrophy of the turbinates. The patient went to the emergency room or to the urgent care on the 26th of February, complaining of clear drainage from his nose and headache and nausea, vomiting. He went to and they gave him a shot of steroids. On the 28th of February, he went to the emergency room with headache, nausea, vomiting, dizziness, pain in the area, clear rhinorrhea since surgery. A CT scan was done, and it showed a large volume pneumocephalus with a bony defect in the right ethmoid sinus. The patient was admitted. He was discharged on the 7th of March 2018. He saw Dr. Friedman postoperatively on the 8th, the next day, and he diagnosed him with a right CSF leak and pneumocephalus. He did a nasal endoscopy with debridement. He referred the patient to a rhinology expert. According to the patient last time, Dr. Friedman told him that it would heal on its own and he didn't need to have it repaired, and that if he did have it repaired, it would probably not stay in place. The patient saw Dr. Reel, who is a specialist. He felt that he was complaining of blurry vision and headaches. He found that the patient had a 10-millimeter defect in the right ethmoid roof with an intrathecal contrast extravasation through the defect. Pneumocephalus, he felt that the patient was at high risk of meningitis and brain and intracranial infections. He told him he needed to close it. He had to do a CSF diversion. He could do it either with an endoscopic transnasal repair, or he might have to have a craniotomy. They performed the surgery on April 19th, 2018. The patient was here last time and told us that Dr. Reel told him that the defect was way too large and it would never close on its own, and he needed surgery.
Dr. Friedman.
Members of the board, first and foremost, I would like to again reiterate how truly sorry I am for my patient's pain or suffering. It's paramount to me that my patients obtain desired outcomes with the least amounts of discomfort. My patient's well-being is paramount to me and at the forefront of my practice and the decisions I make. The decision to undergo a surgical procedure encompasses many factors and was not entered lightly. The inherent procedural risks, anesthesia, Post-procedural care and management are all factored into my treatment paradigm before ever visiting an operative room theater. Patient BH had come to me in December of 2017 with symptoms consistent of chronic rhinosinusitis. Various means of medical conservative management were tried, such as nasal hygiene, intranasal steroid sprays, and other methods. He had suggested having moved from Washington to Arizona exacerbated the symptoms. An allergy test was conducted, the results unremarkable, at which point a CT scan was performed. In review of the CT scan, the sinus findings and deviation of the septum were all noted, and a decision was made to improve on patient's overall well-being to enter into a surgical procedure. Many of my patients who have sinus disease are able to be treated in an in-office paradigm consisting of nasal hygiene regimens and sinus dilations, much like cardiac stents. A simple dilation of any sinus opening can lead to an improvement in sinus aeration and a resolution of some of their symptoms. In this patient's presentation, the septal deviation and a desire to breathe better all were factored in, and that was why the patient was brought to the operative room. At the board's initial hearing and then review again, the reviewing otolaryngologist made note based on the radiologist's report that the surgery did not coincide with the radiological interpretation of the scan. I utilize CT scans to complement and correlate my diagnoses, and I value radiologist input in my patient's care. However, the two-dimensional read of that CT scan does not trump my intraoperative findings. The intraoperative findings I found in real life warrant and dictate the surgeries performed. No other surgeries other than the intraoperative findings of relevance. I agree that the words and the line items are extensive and somewhat long-winded, somewhat difficult to pronounce. However, I can assure you that while there are line items and some complex words, the surgery, some of which steps take a mere matter of moments. This surgery was not extensive. The radiological report not always dictates the amount of sinus disease or patient suffering as the article that I had submitted for the board's review suggests. However, in this particular matter, line by line, the radiological read of the operative procedure performed somewhat correlate. If the board wishes, I can review in detail. As it pertains to the day of the surgical procedure, after obtaining consent, the risk-benefits purpose of the procedure, the patient was brought to the operative room. While anesthesia, 15 minutes induction was taking place, I reviewed the CT scan. From time out to time in, the surgical procedure was 58 minutes in length. There was minimal blood loss, vital signs were monitored throughout the case and were stable, and a small amount of anesthetic was only needed. The complete details of the operative report and all assessments were provided for the board. At no point was an intraoperative complication noted. Had it been noted intraoperatively, it would have been repaired immediately. As soon as finding out of my patient's findings, I personally contacted the skull-base surgeon myself and every step of the way reviewed the care. Upon being discharged from the hospital, pain controlled, imaging all displaying signs of improvement, we scheduled a follow-up with the skull-base surgeon, who is the expert in this, and decided to do a repair. After the repair, I saw the patient. He was doing well, and I was very happy to find that he did not have any long-term sequelae. Throughout the time at the outpatient surgery center, all assessments by myself, nurses, and anesthesia care providers showed no evidence of postoperative pain. All of these notes were provided for the board's review. In no way am I trying to discredit my patient's pain or suffering. This is not the case. I'm merely presenting this information to the board so they can make the most accurate decision when it comes to my medical professional future. I wish only good things on my patients, and I'm very sorry again for any suffering he may have experienced.
Mr. Chairman, members of the board, this case was reviewed by Mark Baldry, M.D. Dr. Baldry states, quote, "It appears to me that the surgery was more extensive than would be suggested from the CT scan," end quote. Dr. Baldry, however, does not state any standard of care whatsoever with respect to any aspect of Dr. Friedman's care. The words, quote, "appear to me," quote, and, quote, "more extensive than would be suggested," quote, do not even begin to state any deviation from the standard of care. In Webb versus Board of Medical Examiners, the Arizona Court of Appeals, in a published opinion, reversed the allopathic board's imposition of discipline based upon its finding that Dr. Webb should have been, quote, "more aggressive," quote, in pursuing the possibility of cancer. The Arizona Court of Appeals held that, quote, "more aggressive," quote, did not articulate either a standard of care or a deviation from the standard of care. I respectfully submit if, quote, "more aggressive," quote, is a completely insufficient basis upon which to base discipline, then the same would have to be the case for an allegation of, quote, "more extensive than suggested." I would also note that the consultant, who, by the way, has adversely evaluated 3 osteopathic ENTs in my career, I would note the consultant does not at all begin to suggest that there is any connection whatsoever between his perception that the surgery, quote, "appears to be more extensive than suggested," end quote, and the surgical complication experienced by the patient. And this lack of a statement connecting a perceived more extensive surgery than that suggested and the complication that the patient experienced may well be due to the fact that the patient experienced what is referred to as a known complication, as indeed is suggested in my letter to this board. Having been against Dr. Baldry several times, I also sincerely believe, based upon those past interactions with Dr. Baldry, that if it were his opinion that there had been a relationship between, quote, "more extensive," quote, surgery and the complication, he would have certainly said so. He did not even suggest any such thing. I respectfully see no grounds for either discipline or even a non-disciplinary letter of concern, and with all due respect, I request that the investigation be dismissed. Thank you.
Mr. Myers, leaving out the fact that I think some of the comments about Dr. Baldry in other cases are extraneous and shouldn't be considered by the board, but that aside for a moment, don't you think we can imply from all the information we receive a standard of care in that surgery should only be performed when required and as necessary, and that what Dr. Baldry is actually saying is that the surgery was performed not as necessary?
Absolutely not. To say that a surgery is more extensive than suggested does not even begin to state a standard of care. The standard of care is that which is reasonable under the circumstances. The standard of care means that if Dr. Jones and Dr. Smith have the same patient, and Dr. Jones does X for the patient and Dr. Smith does Y, it is perfectly conceivable that both have conformed with the standard of care if their care is reasonable. Dr. Baldry needs to state that the care was unreasonable. Dr. Baldry, in order to state a standard of care, needs to state that the standard of care is such and such, and he does not say that. And then he needs to state he deviated from the standard of care. To say that a surgery takes longer than you would have expected based upon a diagnostic image does not even begin to get close to the standard of care.
And I have to disagree with you. I have to disagree with you 100%. He's not saying that the surgery took longer or the surgery or length of time. He's talking about the scope of the surgery. He's saying that the scope of the surgery was greater than what was necessary.
Wait a second. Excuse me.
Please don't interrupt me. Please don't interrupt me. And that the standard of care that can be implied from what he is saying is that a surgery must be performed only if necessary and only as what's reasonable and required under those circumstances. No, I'm not making an opinion on the facts of the case. I'm just talking about the narrow issue of the standard of care. And while Dr. Baldry maybe did not specifically state that in his report, I think it's clear from his report what he's getting at.
Could I have 10 seconds to respond?
More than that if you need it.
Thank you. To say that something is more extensive is inadequate. What would need to be said, for example, we're not talking about time, we're talking about scope.
Right.
Okay. What is it about the scope of the surgery performed that fell below the standard of care? He would have to say that an organ or tissue was removed which should not have been removed. Mm-hmm. To say simply that it's broader in scope, to me, does not say anything, and it also doesn't take into account intraoperative findings.
Mm-hmm. I think that, now you're talking about weight versus the admissibility. I think the fact that he didn't go in, there's not the detail and the relationship to the findings, that's something clearly to consider. But on the issue of standard of care, I think what he's saying that there is a violation of the standard of care by the extensive scope of the surgery. Now, whether he sufficiently backs that up and whether the facts demonstrate that is a different story.
I guess I'll get back to Webb, and in Webb they said you should have been more aggressive, which means do more. That wasn't sufficient. In this case, he's saying you did more than I think you should have done. That's not a standard of care.
Doug?
Okay. Any more questions?
No.
Okay. Dr. Speakerman.
So, Dr. Friedman, he came into you for chronic rhinosinusitis. Is that what's the chief complaint, or chronic sinusitis?
With the combination of, doctor, in addition to that, with the combination of impaired nasal airflow from the septal deviation.
Okay. So he was, even with septal deviation, he's going to be a candidate. So the CT scan was done on 2/7/2018, correct? Or when was it?
If that's the date it reads. I first saw the patient in December, and then over the next 7
But it was a significant period of time before surgery?
Yeah, so before the surgery, doctor, we spent several weeks doing nasal hygiene consisting of nasal...
That's fine. I don't okay. So, but the CT scan was well before the surgery?
The CT scan, I believe, was 3 weeks before the surgery.
Okay, so within 3 weeks, you're board certified, ENT. You go in there, and the CT scan is just that. It's for everybody here that's lay. It's a picture, but it is not the physical thing that you're seeing.
This is correct.
Okay, and the doctor, what's his name? Our consultant?
Dr. Baldry.
Did Dr. Baldry ever examine this patient on or around this time?
No, my understanding is he read the report of the scan.
Okay, well, he read the report. Did he ever actually physically look at the scan that we're aware of?
Doc, I got to apologize because this was your consultant. I don't know if he had, but in my best of my knowledge, I don't think he looked at the scan. It was merely from the information from the radiological report of it.
Okay, and in your opinion, you go to one radiologist or another. You get scans back from different radiologists. Do they have different ways of talking about? So, is there more radiologists that say more things and less things?
This radiological report was actually very thorough, and I can line by line account for his statements in that report with each of my operative line items and the procedures performed in it.
Okay, and so you're an experience in your residency program and outside of that with your teaching and training with your professors that you're doing with. If you found something different within the physical exam and the surgical, you've talked to the patient about, if I find something there, I'm going to do, I would say not more aggressive, I would say more extensive, and that would be something that would be explained to the patient beforehand.
I would think so, yes.
Okay. Thank you. That's all.
Other questions from board members?
No, I have to just expand a little bit from Dr. Speakerman there. The CTs, although a very important component, unfortunately it only shows us what's enough inflammation to be visible on a film. The naked eye can give a lot more information. So just because a CT does not read How extensive a disease is doesn't mean it's not that extensive.
Dr. Erbstrasser?
Well, I would think if you had sphenoid sinusitis, you would see it.
There can be some degree that can be seen and some degree cannot, for the same reason that
Well, enough to do
colonoscopy-
a sinusectomy.
Well, again,
Sphenoidectomy.
for the same reason that sometimes, if I can use a different example, a colonoscopy might be required to see a certain amount of inflammation in a colon that a CT would not. So although it's an important component, it's not the full component.
So, but if you look at the operative report, I mean, it's a complete sinus borat. Complete.
Yes.
All of them. I mean, right ethmoidectomy, left ethmoidectomy, maxillary stuff, bilateral. I mean, to me, I would expect to at least see a little more disease on the CAT scan. That would warrant this. Now, he's a surgeon, I understand that, because when you get in, it can be a different story. But this scenario, to me, can lead to post-op complications, which happened.
You're 100% correct, doctor. This complication was not noted intraoperatively several days after prompt management. The diagnosis that I provided in this operative report, I would like to also note that the skull-based surgeon that I sent them to also coincides with those diagnoses and felt it necessary to further address each sinus. I agree, doctor, that the descriptions of the surgeries are thorough, but some of these maneuvers are very minimal things. For instance, Pasquale's law describes resistance to flow exponentially inversely related to the radius, to the fourth power. So merely taking a sinus stent, like a cardiac stent, and just dilating the maxillary sinus and then doing a minimal unsinectomy, which is like the screen door of a back door, if you will. Just these small moves, several millimeters, doc, right? It improves resistance to flow tremendously. And then when you go back with the nasal hygiene that we've built on for the 2 months prior to the surgery, it makes for improved sinus management overall.
So you're talking a balloon.
It's a portion of it is with a dilatory means, but then with the operative room setting, for instance, a prominent uncinate, you take a backbiter, making certain not to violate the lacrimal duct, and you merely just open it slightly, several millimeters. But because it was done, it needs to be dictated in the operative report. I need to be thorough about these dictations.
Could you also argue, doctor, that it was the CT scan was done 3 weeks prior, and then when he saw you, he had sinusitis at that time?
100%, doc. But this CT scan was done after maximal medical interventions with still persistent complaints. So the operative.
I don't care.
Okay.
Because I'm trying to establish a timeline. Because if everybody's getting you on the CT scan.
Yes, sir.
Okay. And then 3 weeks later we do surgery. I've got kids that are perfectly normal, and because the diagnosis in my practice of sinusitis is 10 or greater days of purulent nasal discharge. Theoretically, then, within that period of time, am I correct in this statement?
Yes.
So he could have developed a sinusitis, which you saw, which would have required the surgeries that you gave. Would that be a correct statement?
This is a correct statement, doctor.
Well, actually, the CAT scan was 16 days
Okay,
before surgery.
Yes, correct. So
Okay.
10 days.
And theoretically, he was being treated with nasal washes and everything, and probably some antibiotics. So, I'm still.
Well, doctor, were those maximal medical therapies stopped prior to the surgery, or was the same regime continued up to the?
No, I always stress the continuation of such. If you think about a 2-lane highway, there's 2 reasons for a traffic jam on a 2-lane highway. One being construction in one lane or an overturned tractor trailer. And then with busyness or congestion, when all these cars are trying to merge like this, you get a backflow, pressure, congestion. Now, the road construction is done, the overturned thing, the rubbernecking is all done. But when winter's upon us on a 2-lane highway and we get a snowstorm, it leads to inclement driving conditions, slower cars, and traffic and congestion for a different means. So even though both lanes are patent, the environmental aspects lead to congestion and similar findings. So it's a 2-prong approach, both medical and surgical.
So I'm sorry, the maximal medical therapy was continued up to the.
Yes, I always urge continued nasal hygiene consisting of saline and intranasal steroid spray aimed towards the eyes to coat the lateral nasal mucosa.
Thank you.
The only question I had, and I know he said he didn't find any fault. Have you had these complications before in the past when you've had this type of surgery?
This was the first time I've ever encountered a pneumocephalus with CSF rhinorrhea. Being confident in its management, we implemented the initial bed rest, antibiotic prophylaxis for meningitis, and that very day I called Dr. Ryan Reel for his assistance. He told me and guided me through every step of the way. It was determined we were going to do a week of bed rest to see if it was going to get better. The radiological scan suggested such. At the follow-up visit, it was Dr. Reel's professional opinion that a procedure should be done to correct it. I agree. Much like the osteopath decrees, the body has a potential to heal itself. So I think giving it a week and being on top of this patient every step of the way, I feel a week to see if it gets better is not wrong in its management.
Is the complainant here?
Yes, the complainant is present.
Can I have the complainant come forward, please?
BH.
Welcome, sir. Thank you. Have a seat right there. Can you swear the complainant in, please?
Yes.
And speak right into the microphone. Thank you. You've heard we've been discussing this for a while. And is there anything you'd like to add?
Yes. Can I ask a quick question?
Sure.
I heard something about 10 millimeter defect. Do you have a time frame as to when that was measured? Is it like?
I don't know. I don't know that.
I can look it up.
There was an initial evaluation after return to the emergency room, if I remember correctly. It was mentioned by the neurosurgery.
Okay.
Go ahead.
So there's a few things I want to bring up. One, I was in the hospital a lot longer than was talked about. I was originally, after the first surgery, I went back to Osborne. I did go to urgent care. I did get the shot of the Toradol. And a few days later, I ended up having to call an ambulance. I couldn't even walk. They brought me in. I was there for 7 days. They did a CT cysternogram. I still was flowing a lot of the CSF. I couldn't even lean forward without it just pouring out of my nose. After 7 days, I was sent home. I was home for, I believe it was 7 days. I went back to urgent care to get another shot of Toradol because the massive headaches were returning. And while I was there, I had another episode where I was just covered in perspiration, vomiting in the waiting room. I had to be wheelchaired back, ambulanced back to Osborne a second time. I was there for another 8 days. I had a second CT cysternogram while I was there, and the initial radiologist stated that I did, in fact, still have a CSF leak. I do not know for a fact who asked for the second opinion, if it was somebody, the medical staff or Dr. Friedman, but someone asked for a second opinion. Another radiologist read or looked over the results and said that there was no more leak. I stated that I still, if I lean forward, just on the one side, my nostril will get wet. It's not pouring out like it was before, but in the matter of 5 or 10 seconds, it's still getting wet. I still was showing concern that I don't think I'm healed, but I was sent home anyways. And Dr. Friedman gave me the option. He said, you can keep your appointment with Dr. Reel if you would like, but from what we can see here, you're healed, you're good to go. I decided to obviously keep my appointment with Dr. Reel, and he immediately said, I did a CT scan there in his office, and he said that without a doubt you absolutely have to have surgery. He said you'll be on antibiotics for the rest of your life to avoid meningitis. If you don't get surgery, this will never heal without intervention.
Questions from board members? Any questions, Dr. Speakerman, Dr. Erbsroster?
Well, I just think about the timeline from when you had surgery and then first surgery and then you had second surgery. The first surgery was on 2/23, and then your second surgery from Dr. Reel was on 4/19/18. And I mean, it sounds like you had a lot of pain and suffering during that interval.
I've never, I think we all throughout life at some point in time we go through some kind of physical pain. I've never felt anything like this before. I've never been to the point of vomiting, becoming so nauseous that my whole body is drenched in sweat. There's one other thing I want to add also. I forgot to say. Immediately post-surgery, when I woke up, I know I had just woken up from the anesthesia, but probably within 30 minutes, I was in incredible pain. I had not left the surgery center from my first surgery, and yeah, I mean it was a big concern. I already had the CSF flowing from my nose. It was not something that developed later. It happened right there. I hadn't even gone home yet, and I was the nurse. I specifically remember my friend who picked me up. He had to wait quite a while before they would even let him come back. Because I had to stay there so much longer so that they could get my pain under control. The nurse, this sounds weird, but I think she questioned if I had like wet myself, because she questioned why my bed was so wet, and I said I'm covered in sweat, because of all this pain. And they gave me morphine. Still was in horrible pain. They gave me more morphine. They gave me fentanyl, and then they gave me Percocet. And then they said, "Where's your pain at?" After they'd given me 3 different narcotics, and I said, "I'm maybe a 6 out of 10 at this point." And they said, "Okay, sounds good to us."
How are you doing now?
Now, as far as Dr. Reel is concerned, everything is healed. Everything looks good. I do still have these occasional headaches. No, they're not anywhere near as severe as before. They do always start kind of in that same exact area. I don't know if it's a concern at this point, but it's more annoying than anything. But as far as just living my day-to-day life, I can't say that I'm inhibited.
Thank you so much. Any other questions?
How many times did the doctor call you, talk to you, visit, anything like that? Would you say that he was at least, even though you weren't happy with the care, was he attentive, is my question?
Yes, he was. He showed up to the hospital multiple times. He absolutely did seem concerned.
Appreciate that.
And I'm not going to be dishonest about that.
No, we appreciate that.
Do you feel like when he talked to you, it was in a way that you could understand? Did you understand, and did he explain things in a way that made sense to you?
Yeah, it made sense to me. I mean, as much as it can, not being a medical professional.
Sure. Maybe compare it to Dr. Reel that you're seeing now. Does it make as much sense as what he explains to you?
As far as the way both of them explain things to me, they do make it easy to understand, and I don't necessarily leave confused. I think it was from the time that I was told that there was a defect until I had my second surgery, almost 2 months of time. I just don't feel like the advice I was given was in my best interest.
Okay, thank you.
You're welcome.
All right. Any other questions from board members? Thank you so much. Very insightful. Thank you for coming down here today. I appreciate it. If you want, you can step back, or you can stay there, whatever you'd like to do. All right.
Is it okay if I say?
Sure. Yeah, absolutely. You certainly can. Anything else you'd like to add, Dr. Friedman?
I am sorry for the pain my patient experienced.
Any other questions from board members?
No.
Okay. I think that you went through a very difficult experience, and I'm going to tell you that in my career, I hate to say this to everybody in the room, 30 years this July I've been in practice, okay? I tell everybody I'm 39, but I don't think they believe me anymore. But in my career as a primary care doc, I've had 3 cases that have happened like this from having sinus surgery. It is a known complication. It's not a good complication, I'm going to just tell you. And it's very difficult to get through. And I understand I have never had it, but I've seen it with my patients. So I understand the pain that you went through. But I'm going to tell you, I'm so sorry that happened to you. I really am. That being said, I don't see where the doctor was negligent that he didn't follow through with you. I think he made sure that he tried to get you the care and the thing they're saying here. And again, you went through a very difficult process. I think you tried to go through a conservative way first without having to go back through surgery and so forth. So that being said, I'm, again, very sorry for what you're doing. I'm just glad you're better. That's the main thing. I'm glad you're better. Any questions from other board members? Anybody else want to say? Can I have a motion?
have a motion to dismiss.
So I have a motion for dismissal. Can I have a second?
Second.
Second. I have a second, Dr. Madam. Any discussion before we vote?
The only thing I'd like to say is, in the future, with these, because like he was saying, is a difficult case, have a less threshold to get him to that surgeon early. You know what I mean? It's like if you get this pneumocystis deal, it's uncommon. Get him immediately to the specialist and make them see him instead of I don't want to. You know what I mean? Just say I need you to see this patient.
100%, doctor.
Okay.
The day it was brought to my attention, I called this myself.
Because
you're right.
That's why we're here. Is because if he said you were a nice guy, you did the right thing. But the problem of it is delayed care is why you're here.
I understand.
Yeah.
Okay.
Can I have a roll call, please?
Yes. Mr. Berg.
Yes.
Dr. Speakman.
Aye.
Dr. Madam.
Aye.
Mr. Landau.
Aye.
Dr. Erbstrasser.
No.
Dr. Cunningham.
No. But motion passes. The only reason I'm saying that is because I think he could have reacted quicker, okay? I don't think he deviated from the care, but I think he could have reacted quicker in talking to you, okay? And I appreciate your coming down here and talking to us, okay?
Don't go anywhere. I want to go back to the other cases. One thing I wanted to add, I didn't in the motion.
You're set to go if you'd like. Thank you, sir.
Thank you.
Thank you very much. I didn't put an end date, a required date on the CME. So if we could recall 180141A.
Dr. Cunningham, could we vote to go back to the previous case?
Okay. Can I...
I'd make a motion, then we would go back to the previous case.
Second. All in favor signify by saying aye. All opposed. We're going to go back to the first case.
And
Dr. Friedman.
I'd just like to note that I'd like to append to my motion that the CME be completed by December 1st, 2019. I think the class is in October, so December 1st.
We have a second. All right. All in favor signify by saying aye.
Aye.
All opposed, same sign. Thank you.
Thank you. One other thing. Dr. Friedman, you've been a physician for 11 years. And, be it doctor or attorney or maybe some other professions, there's a decent chance in all your long career there could be a complaint against you somewhere down the line. But you're here for 3 cases one day, no matter what the outcome. And listening to all these discussions, there is within your office, I think, a systemic issue you need to deal with. And you really need to look at how you practice, and from a procedural, maybe not from a medical knowledge standpoint, but from an operational standpoint, and how you run your office, and how you train your staff, and how you interact with everyone, and how you maintain your records. There's an old saying that you make your own luck. It gets to be, and there are other old sayings, there's no such thing as coincidence. So really, I suggest you take a look at your practice and how you do things. You have a long career in front of you. You see a lot of patients, and it's so important to keep on top of all that stuff, because it can get away from you. And this is for our medical students as well. It can get away from you real quickly.
Mr. Landau, I hear the words coming out of your mouth, and I hear you.
Okay,
good. All right, good luck to you.
Thank you. We don't want to see you here again. You just burned 8 of your 9 lives.
Yeah. I just need to grab my class.
All right. Do we need a break, or is everybody doing okay?
I'm good.
No, all right.
But I'm sorry, Gene, this just as a point of order for that change that Mr. Landau just made, does the seconder from the initial motion have to accept that as a friendly amendment, or are we fine just to vote for it as we did?
We had a second.
No, not that.
And it was like a clarification.
Okay.
Thank you.
Glad you said that.
Nah, just leave it. Hope we normally use a citrus, right? Okay. Oh, I just want to grab my cup. Okay. I'm going to go ahead and call the case if that's okay. All right. Next case is DO-17-0286A, Harold A. I'm sorry if I say this wrong. Taby, DO, license number 005237. Dr. Taby? Welcome, doctor. You can just have a seat right there. And if you can introduce your counsel that's with you as well.
Paul Giancola.
Welcome, Mr. Giancola. Can you swear in the doctor, please?
I do.
Okay. Doctor, can you tell us a little bit about your training and the type of practice that you have now?
I went to...
Talk directly into the microphone, please. Thank you.
My training started actually at University of California. I have a PhD in cardiovascular physiology. I went to medical school in Michigan. Did my general surgery in New Jersey, School of Medicine and Dentistry. Then cardiac surgery at Cleveland Clinic.
Okay. And you're practicing where?
I'm board certified in general surgery and cardiothoracic and vascular surgery. I've been practicing cardiac surgery for the last 27 years, as well as vascular and thoracic. The last few years, I've been doing mainly minimally invasive vascular procedures.
And you're in practice where now?
Los Angeles.
Los Angeles. Okay. You want to review this? This is John's, as I recall.
Yes, sir.
Correct.
On November 15th, 2017, a disciplinary alert report was received from FSMB advising of disciplinary action taken against Dr. Harold Tabay by the Osteopathic Board of California on November 14th of 2017. Dr. Tabay did not report this action when he renewed his Arizona osteopathic license on November 22nd, 2017. This action was the result of two surgical procedures where the California Board determined that Dr. Tabay fell below the standard of care. There was also an incident where the California Board determined that he altered a surgical record after the procedure was completed. Dr. Tabay did not respond when first noticed on this complaint in November of 2017 and was subsequently noticed a second time in May of 2018. His formal response was not received until November 19th of 2018. Dr. Tabay responded that he signed a stipulated agreement with the Osteopathic Board of California. The first case was a 74-year-old woman with multi-symptom disease and an abdominal aortic aneurysm with a diameter between 5.5 and 6 centimeters. Dr. Tabay states that given her general medical comorbidities, he felt an endovascular approach to repair this aneurysm was certainly a good decision. Dr. Tabay states that the patient chose to have the endovascular approach with the additional stipulation of not allowing an open abdominal approach under any circumstances. When there were complications, Dr. Tabay felt obligated to reconfirm her feelings with the family at this point regarding the lack of consent for intra-abdominal open approach. He left the operating room to rediscuss and reconfirm the patient's decision with the patient's family. The patient later died. Regarding the alteration of a surgical record, Dr. Tabay reported that he placed an addenda into the operative report and also a subsequent letter that was signed and witnessed by the patient and the medical office secretary. Dr. Tabay states that changing the operative report would be considered inappropriate under certain circumstances. But Dr. Tabay feels that placing an addendum or changing the wording as long as the original report remains is clearly not fraudulent nor beneath the standards for documentation of care and is actually desirable. He feels the goal is to have a medical record that most accurately and truthfully describes the actual facts and situation. He also feels that as long as this was not done with fraudulent intent, it is clearly not beneath the acceptable documentation standards to do so. The second case involved a 59-year-old gentleman with a history of ischemic and gangrenous left great toe. He was found to have severe left superficial femoral artery disease with significant impairment to resting perfusion of his left foot. He subsequently underwent angiography and a successful revascularization of his left leg and underwent an open amputation of his left necrotic toe. He later developed rest ischemia of his right foot, and eventually Dr. Tabay attempted an endovascular revascularization of his right leg. Dr. Tabay was unable to traverse the complete occlusion of his distal right superficial femoral artery and had to stop that procedure without success. On the subsequent day, the patient was taken to the operating room where Dr. Tabay performed a right above the knee PTFE synthetic bypass, and then because he was unable at the time to traverse the popliteal artery, he performed an endarterectomy to patch angioplasty closure. Due to ischemia and pain, the patient subsequently underwent a right below the knee amputation.
Okay, thank you.
I'm not sure I pronounced everything correctly, but
you did very well. All right, Dr. Tabay, do you care to respond?
Dr. Cunningham, may I speak first and then Dr. Tabay? Thank you. As was noted, this was a California Medical Board disciplinary action, and the reason this board was not initially notified of it is Dr. Tabay had asked his attorney to notify all the states where he was licensed, and the attorney did notify Florida and Michigan and somehow did not notify Arizona, and Dr. Tabay was not aware of that when he then went for relicensing here, so he apologizes for that. Apparently there was also a mix-up in terms of office addresses, in terms of getting correspondence from this board, and so there was a very long delay in getting notified of this and providing a response, for which he does provide he is sorry as well. Dr. Tabay was very modest in terms of his background and qualifications. At the time in 2012, he was the chief and director of cardiothoracic and vascular surgery at Emmanuel Medical Center. Over the years, as noted, he did complete his residency in cardiothoracic surgery at Cleveland Clinic. He stayed on there as an associate. He's well published. He's done a lot of research. One of his areas of interest and publication has been robotic surgery of coronary artery vessels. And he's spoken nationally and internationally, and for whatever reason, he did not include his CV in his response. I'm sure you've had other physicians who have been disciplined by the California Medical Board. I can tell you in my career, it's a very unique animal. It is probably one of the toughest boards in the country. And the one error in the presentation by the investigator was that he said the California Medical Board made determinations. There were no determinations in this case, because in California they do not have a process like you have here where a physician can come before the board as part of an investigative hearing. You have to actually go before an administrative law judge who basically will take a week or more for a trial, like a medical malpractice-like trial on all of the allegations with experts and witnesses and the like. And it's time-consuming, it's expensive. You can win at that level, and the medical board can still decide that they do not wish to accept the findings of fact and conclusions, and will discipline you anyway. So most physicians in California, if they have the opportunity to, will enter into a stipulated consent agreement. So that's exactly what happened here. And so in your papers you do have the consent agreement, and what it does say, which is very clear in regard to culpability, it says that the respondent agrees that at a hearing a complainant, meaning the California Medical Board, could establish a factual basis for the charges in the amended accusation, and that the respondent hereby gives up their right to contest the charges. So basically what you admit is that the California Board could present evidence that would sustain the charge, but of course you, as the respondent, have the right and the opportunity to submit evidence contrary to that, which the judge will hear and make a determination of fact as to whether or not there were deviations from the standard of care. As noted in Dr. Tabay's response, he did have an expert, Dr. Shore, from the Stanford University Medical Center on both of the cases. I would also note that in the California Medical Board stipulation, it notes that Dr. Tabay has never been disciplined before. That's on page 3, paragraph 12. He is admitting responsibility at an early stage in the proceeding, and he has been performing surgeries in his private practice for the last 3 years without incident. I would add to that that's now 7 years since these cases occurred back in 2012. With that in mind, Dr. Today will discuss with you the cases, but as a reasonable way to resolve these cases, he agreed to a letter of reprimand, which is the lowest level of discipline in California. He took extensive CME and documentation ethics, and his practice was monitored for 6 months, where there were random chart reviews to ensure that he was practicing within the standard of care. He successfully completed all of those. He now has an office scribe which assists in the documentation. And for me to briefly just discuss the two cases, one SZ, the first one was the triple aneurysm case. The unique piece about this case is that this was an emergency surgery. He had discussions with the patient about limiting the procedure to a local anesthetic without going into an open anesthetic. She had multiple comorbidities. But when the emergency came up, the hospital had the normal consent to treatment. He then left the operating room to confirm when there was a complication that the patient had continued to not want the open procedure. He left the patient with an anesthesiologist and another board-certified cardiovascular surgeon. The family confirmed that they did not wish to have the procedure. It was risk management that then came to Dr. Tabai and said, hey, can you add to the medical record by creating an addendum of your conversation with the patient in the office? He did that, and that was the OR addendum. The then quality management came to him and said, can you get the patient to write a letter, meaning at this point in time the patient had died, so the patient's daughter to write a letter about what occurred. His office then contacted the patient. She came into his office. She gave the office a handwritten statement. The office staff typed it up. They unfortunately mistyped or misspelled the patient's name, and in front of the witness in the office, and Dr. Tabai can give you more details about this, the daughter signed that. So those were the real documentation issues. Obviously his documentation was inadequate. He does not dispute that, but certainly there was no fraudulent intent or anything like that with either of these, and he wouldn't have even gone down this direction if not requested to do so by hospital.
Excuse me, can I interrupt for 1 sec? I'm just curious to what the board thinks, which is either way. Do we want to relitigate the California cases or stick with the failure to report, or both?
I think there's a problem with both. I don't want to relitigate the cases, though, but I do think there's a problem here with him. And then I think there's a problem with his failure to report and also timely response to this as well. And so I think that should be the main focus. Okay. That's the main focus. So I really don't want to get off into going through everything. I don't want to relitigate those. The California board, I'm looking through their findings of fact, and I'm satisfied with them. He signed a consent agreement, so I'm not going to dispute how the California board goes one way or the other.
I will note also, coincidentally, being an officer and a board member of the Federation of State Medical Boards, we are assigned certain boards throughout the country to be liaison. And coincidentally, the Osteopathic Board of California is one of the boards. I am the liaison. So I have been to two of the board meetings and have seen a number of the cases. And while it's procedure, California law, and procedure is different than Arizona, I'm clearly satisfied there is due process for the physician and for the public in the state, and the physician does have an opportunity to be heard in the process. I just throw that out.
Then I will not address the second case, which there were a great deal of differences on medical opinion, and just simply say that Dr. Tobias accepts what California did. He recognizes this board has the ability to discipline him simply based upon the fact that there was discipline in another state. He has gone through extensive efforts to mitigate and complete all of the mitigation requested by California, and he is practicing successfully now without incident, and apologizes for the lack of timely notice to this board, and would be happy to answer any questions for you. Do you want to say anything?
Do you have any statement you want to make, Doctor, before we start asking questions?
I do appreciate the opportunity to talk. It is true that there was no reason for me to not respond to any questions or letters from the board. I truly did not receive it. The mail was sent to a different address to someone by the name of Dr. Marriott, which I did not receive. And I successfully renewed my license. I had no reason to hide. This is not the era that you can hide anything. Everything is on the internet and on our record. So I truly, I'm sorry that I sort of felt that the board, I was misleading the board for not responding. I did not receive the letter. Once I did, I responded, and I also spoke my previous attorney, and he apologized for failing to send the same letter that he sent to other states that was supposed to be coming to Board of Arizona, somehow was missed. So for that I apologize. And we don't want to talk about cases, of course, but any questions you have about this?
Questions from board members. Go ahead, Dr. Madam.
Just so it's said that it's okay to ask your lawyer to send notification, but it is your responsibility to make sure it's done.
I agree.
That's all.
Well, the address sent was 222 North Sepulveda Boulevard.
That's Dr. Marriott's address, yes. We were associated at one point. I was asked to start a mobile vascular sort of program, and we did that, and then I went back into my own corporation and we started.
At a different address?
Correct.
Did you notify this board of your change of address?
I believe my new office did. I am not sure when.
You don't know?
I am not sure. But the fact is, all the other boards had the new address, and I'm not sure why this particular problem occurred with Arizona.
Your other boards were notified of the disciplinary action, and it's clear that Arizona was not notified. So it sounds as if whomever was responsible is ultimately you, that Arizona was skipped in the process.
Well, as I mentioned before, I relied on my attorney to do that because that's a really normal process, and he's very well aware. He's also an MD and JD. Somehow he says his office failed to do so, and I should take the responsibility naturally because I should have followed through and made sure that all the states had the letter, and I apologize for that.
So, can I ask a question?
I'm done, thanks.
So my question was, you signed this stipulation with the California Board on March 2, 2017 for your consent agreement, and then you went to renew on November 22nd, 17, but you did not disclose. Is that correct?
I'm not sure if there was a question that I did not disclose. I'm not sure.
Question
I
number
can't
2.
remember.
Go ahead, hang on a second. So he did, Justin, tell me, remind me again, he did not disclose, is that correct?
That is correct. I can pull up the question.
That's the problem we have here at the board. That's the problem I have here, is clearly you signed on March. Doctor, you got attorneys, those things, I don't care. It's on your shoulders, okay? To me, when you don't respond to the board, You don't let us know about your address. I don't know if you did or didn't. You can't tell me one way or the other. You have no proof one way or the other. And then also you didn't disclose, from what I'm understanding, here, when you already were on March 2017, I have a problem of credibility with you before this board.
Yeah.
What's your current practice address now?
It's we have several different addresses, but the main address that
One
we
where
have
you would
is
get
off of
mail at.
Ventura. It's 18905 Sherman Way, Reseda, California.
And have you moved to that address since November 22nd of 2017? Is that a new address since November 22nd of 2017?
So we have different addresses.
Okay. Would you receive mail at 4527 East Cesar Chavez Avenue?
Yes, we did. Yes.
You would receive mail there?
Right.
Okay.
You did or you do?
We do. We do receive mail. I'm not sure if I received any. I'm sure.
Okay.
If I had received a letter from the board, I would have.
What address do we have on file?
One on the application.
Yeah. Are these? That's the one we would pull over to our official files. The Chavez.
Do
we update these automatically, or there's a specific form the doctor needs to
Anytime if they renew online, they would update their address. That would be updated automatically. The current...
I guess that's where I was going with this, is that on November of 2017, he provided a practice address of that Cesar Chavez Boulevard, but we noticed him at 222 something else?
He had designated a particular mailing address from the board that was a different address than
Different
that.
from the practice address?
Different than
Which
the
you can
practice
do.
address. But the Cesar Chavez was the practice address until May 7th, 2018, and then it was updated to the Sherman Way address.
When was that updated?
The Cesar Chavez address was his practice address from November 22nd, 2017 to May 7th, 2018.
Okay, so after May 27th, 2018, we never got an update to change it back to wherever it needs to go now. Okay.
Can I follow up on your question, please, Jeff? Could you, Dr. Tybee, go to page 2 of your renewal application? Do you have that in front of you?
We don't have that.
Could we get a copy
Sure.
of that to the doctor?
Just read it to him.
That's what I was
What?
Go ahead, Justin. Yeah. Do you want to take a 5-minute break while you get that? Would that
He's
be the
gonna
best?
give him the
He's going to
laptop.
show him his.
I'm sorry?
He's
Oh,
gonna show
shows
him.
on there. Okay. Okay.
Is this your renewal application, doctor?
I assume.
This is your renewal application, correct?
Correct. I can see that the answer is no.
Right. The question is that you had have you had any disciplinary or adverse action opposed against any professional license? And it goes on from there, and you answered no. That's not a true statement, correct?
Absolutely, it's not a true statement.
Okay.
My failure is that I have my office fill these applications and I sign it, and of course, since this episode, things have changed, but I take responsibility. This is not what I meant to have, and I actually overlooked this, and I apologize. There was really no reason for me to. It's not something that you can hide.
I would just note, just in terms of temporal timing notice, that the actual declaration of service by mail from the California Medical Board to Dr. Tabai and his attorney, it's executed on November 14th of 2017, and it was not effective until November 29th of 2017, and it was filed on November 14th of 2017. So although he had signed things in advance, there was everything was still not final.
Yeah, but the question says, have you been notified or made aware?
Yeah.
That's
So
legal.
I'm not going to take that.
Yeah,
I'm not going to do that.
that's attorney stuff.
You're not helping your client, sir.
Your client wanted to say.
What do you want to do?
Good try, though. Yes, yeah, he does have to point that out. In all seriousness, I think Giancola does need to point that out.
I have a problem with the doctor for this, so let's just go. Can we go into
executive
session for legal advice just for a minute, and then I'll be right back. I have a motion. Second, all in favor, signify by saying aye. Aye. have executive session for legal advice. And Mr. Landau.
Mr. Chairman, I'm going to make a motion that we find a violation of ARS 32-1854-15 that Dr. Tybee knowingly made a false fraudulent statement in connection with the practice of medicine or when applying for renewing, in connection with the practice of medicine, and further violation of 1854-18 that he denied disciplinary action against the license by state and territory, specifically California. And that is my
motion.
That is my motion.
I have a motion from Mr. Landau. Can I have a second? Oops.
15 and 18.
Right.
Okay, thank you.
Okay. I have a motion.
Second.
And I have a second from Dr. Madam. Any discussion before we vote? Okay. Can I have a roll call, please?
Yes. Mr. Berg?
Yes.
Dr. Speakerman?
Yes.
Dr. Madam?
Aye.
Mr. Landau?
Aye.
Dr. Erbstrasser?
Yes.
Dr. Cunningham?
Yes.
And, Mr. Chairman, I move that this board issue a censure to Dr. Tybee and impose a civil penalty of $1,000.
Okay.
Payable in what period of time?
Payable, what are we in, August? Yeah, payable by October 1st, 2019.
Second.
I have a motion from Mr. Madam, a second. Who's the second?
Mr. Landau.
I'm Mr. Landau. Who's the second?
Me.
Dr. Speakerman. Any discussion before we vote? I have a roll call, please.
Yes. Mr. Berg?
Yes.
Dr. Speakerman?
Yes.
Dr. Madam?
Aye.
Dr. Erbstrasser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes. Thank you. Good luck back in California, sir.
Thank you.
Thank you.
All right, let's go on to the next case. Is EDO-18-01818A, Mark Christian Carnett, DO, license number 3174. Dr. Carnett, can you come forward, please? Welcome, doctor. And if you can introduce your, that's just for a second. Can you guys introduce your counsel then for us?
Mr. Langen. Tony Langen with Udall Law Firm in Tucson.
Welcome. Can you swear in the doctor for us, please?
Yes.
Okay. Doctor, can you just tell us about your training and the type of practice that you have now?
Sure. I graduated from Chicago College of Osteopathic Medicine in 1990, completed my family medicine residency at the same institution, and I currently have a family practice in Sierra Vista, Arizona.
Dr. Pry, I think this is yours.
Yes. This case involves a 75-year-old male that was seen by Dr. Carnett in 2011. Originally, he was seen on August 27, 2014.
77-year-old male, by the way. Correction.
He was, yes, okay. 77 by then.
Okay.
He was ordered, lab was ordered, which included a PSA, but the PSA was not documented. Dr. Carnett advised the patient to call the office for lab results in a couple of days. The lab was drawn at Canyon Vista Medical Center on August 29, 2014, and the PSA was abnormal at 4.62. Canyon Vista Medical Center reported the results were sent to Dr. Carnett's office. The patient was not informed of the abnormal PSA. The patient returned to the office on September 3, 2015, with symptoms of urinary obstruction and suprapubic pain. A PSA was ordered and showed a level of 12. A repeat PSA was ordered on October 1, 2015, and this was also elevated at 14.4. The patient was referred to a urologist on October 6, 2015. On November 13, 2015, a prostate needle biopsy showed a high-grade malignant neoplasm. PET scans and CT scans showed widespread osseous metastatic disease with spread to the lymph nodes. The plaintiff's attorney states that the patient and his wife were told by the oncologist that if the patient had been timely diagnosed and referred for appropriate care, his chance of recovery, or cure and full recovery, would have been good. The issues with this case was that Dr. Carnett failed to follow up on lab ordered in 2014. He failed to notify the patient of an abnormal lab finding. I felt that he may, if he had realized that the PSA was abnormal, he would have had the opportunity to repeat that in 2014. It appears he does not have a tickler system for follow-up on ordered laboratory diagnostic testing or referrals. He expected the patient to be responsible for the follow-up by telling him to call the office within a couple of days. Dr. Carnett may have considered referring the patient to a urologist when the PSA was found to be elevated in 2014. He failed to immediately refer the patient to a urologist and an oncologist in 2015 when his PSA was 12, but instead repeated it approximately a month later and then waited another month before he was referred.
Doctor, go ahead.
If I can speak.
Or I apologize. No, didn't wait. No, I apologize. Just waited another month.
Okay, go ahead.
I would like just to first address the actual harm identified, because there was, earlier this morning, I know you guys have talked about preponderance of the evidence. There was an underlying lawsuit in this case with Canyon Vista Medical Center and Dr. Carnett in it. Our expert, John Glaspie at UCLA, who's a fairly well-respected medical oncologist, felt that there was no chance of cure even in 2014. He felt so because there was a high PSA velocity. The treatment that the patient had was castrate resistant, and he also had a Gleason 9. So in regard to the harm, Dr. Glaspie, it was going to be his testimony that there was no chance of cure as of 2014. So I just wanted to point that out. And in regard to standard of care, we believe Dr. Carnett can explain why he feels he met the standard of care and what changes he has now in his practice.
Is that really the issue? The harm versus
I was just pointing out, Mr. Landau, I didn't want people to assume that we caused this man's death, because that was strongly disputed in this case.
Okay.
No, I agree with you.
I think that's a good argument.
Go ahead, doctor.
Okay. In regards to when I saw this patient in 2014, and really what I can really tell you is that this is off my notes. I don't remember seeing that patient personally. It was 5 years ago. There was nothing notable about that visit that would make it a memorable episode. When he came in for a physical in 2014, we ordered labs. I did order a PSA also, though it was not noted in the chart. The only explanation I can have for that is at that time we were using paper order sheets. We had a sheet we'd sit and circle and so on, and it could very well be that when I dictated, I omitted it, or my finger slipped off the recorder. I don't know what happened, why it wasn't noted in the chart. But it could have very well been that as the patient was going out, he said, "Hey, I want to order a PSA." He was at his age. Normally, it's not recommended to even order that unless they have symptomatology. So that's all speculation on my part, exactly what happened in that situation. Throughout the years, we've always had some issues getting faxed reports. Canyon Vista Medical Center not alone in that Sonora Quest and LabCorp and even consultant reports, sometimes the faxes don't come through. In 2014, we had a standard laser fax machine, Brother fax machine. We would get 250 to 300 faxes over a 24-hour period. It's certainly possible that one of those sheets got jammed, got destroyed. I don't know. Those sheets would then be taken, they'd be sorted by a staff member and put into the chart so we could then review them all. So I don't have any other explanation other than I didn't receive it at that time. Being that was an ongoing issue with any other reports even getting in, I always made it a point to say, make sure you call us in a couple of days so you can get the results, because sometimes we don't get them. And that way, I was hoping that would be the adequate way. We want to involve the patient in their patient care, and we tell them to contact us so we don't get an endless phone tag and so on. Since that time, 2015, when I saw him, he came in with some lower urinary or lower abdomen pain, but by the time I saw him, that had resolved, and on examination, he really didn't have any pain in the suprapubic area whatsoever. By 2015, we had gone to electronic ordering of laboratory with SonoraQuest and LabCorp. Canyon Vista still does not have that system in place. So by doing that, we now have an electronic record of what was ordered, plus we can then put task reminders on there to make sure that we get follow-up for results as well. And those reports, when they do come in, can now be viewed by the patient through the patient portal as well if they elect to sign up for that. So at that time, I saw him. I ordered another PSA. I ordered, and I told him then I didn't have a result from the last year. I ordered urinalysis. Urinalysis came back normal. Everything else was normal except for the PSA was elevated. By that time, he didn't have any symptoms when I saw him, so I thought, well, at his age, perhaps he has some BPH, perhaps he had a UTI, perhaps his urinary system cleared it, and this is possibly a false elevation of the PSA. So I said, let's go ahead and repeat it again in a month and see where we're at. It came back elevated again, and I discussed with him and his wife that he needs to see a urologist. There's certainly a good chance that there could be some prostate cancer there. As far as waiting the month, it's very unexpected that someone at this age would have such an aggressive prostate cancer. If he was 54 years old, it would have been a different story. But in his mid-70s, it was shocking that he would have this type of a cancer so quickly. And I referred him, that day. It was a month until he was able to get in to see the urologist, and I don't know if he specifically said he wanted to see a doctor in Tucson or one of the urologists in Sierra Vista. We only have two in Sierra Vista at that time. So as far as that goes, I don't know why it was Tucson that he chose, that he requested that, or what happened in that respect. But again, figuring at his age, the likelihood of this being a aggressive cancer to me at the time, obviously in hindsight, yeah, it was. But I've got a lot of patients that have BPH and have PSAs of 14 also. So, questions?
So you didn't think, and I great part defer to my medical colleagues, but you didn't think it was urgent enough to tell him, see a urologist and see a neurologist. Now, I had a doctor tell me that he's walked patients over to the cardiologist. Right. You didn't feel it necessary to tell him, go there and then go there now.
And he was essentially, he was very asymptomatic. He wasn't having urinary retention. He said it didn't urinate as well as he used to, but who doesn't at 75? And so, nothing, popped in my head saying, boy, this has got to be prostate cancer. At the time, that's not what I'm thinking. I'm thinking it possibly is, but if it is, something else may get him before the prostate cancer does. But this is the 1 in a million exception here.
Do you think that your office should have the responsibility to contact the patient with lab results?
Yeah. Absolutely. I tell patients, as I did then too, we want to make sure that you get your lab results, whether they're normal or they're not normal, because I've heard too many patients say, well, as they're leaving, I'll tell them, call us to make sure we got the lab results. Well, no news is good news, right, Doc? I'm like, no. I say, that's not correct.
Now, that's not what I asked. The question was, do you believe it's your responsibility to affirmatively call the patient with the results as compared to telling the patient to call the office in a few days for your results?
Right. I do now. At the time, in 2014, I felt that if I instructed the patient to call, especially for annual physicals, I don't know when they're going to have it done. They may have it done the next day. They may have it done a month later. I've had some a year later, they still haven't done it. And it seemed to be somewhat of an insurmountable task to be able to track every single lab order that we did at the time, and to be calling people every week to say, did you get your labs done yet? Did you and doing the phone tag.
Well, no, it's not so much.
I think it is our responsibility to get the results. Absolutely.
Yeah, the results.
Absolutely.
So, Mr. Landau, we had to change this for Micah here. So our computer system, because there was these types of situations, when you place an order, okay, for a lab, if it's not done within a month, then our staff will actually contact the family and say, do you want to cancel this? Do they not want to do it? So, and then our mechanism is to either sign off on that, or they will, or if you can't get a hold of them, you'll send a letter. And then somebody from our office will get back to them. In my experience, there's a lot of people that don't do it. It's very, unfortunately, time-consuming. But I will tell you, in 2014, it is, I would say that was 2015, 2016 is when we started to implement that within our computer system. So I would argue in 2014 that what he was right now, it would not be appropriate. But in 2014, there was a switch, so that would have, when I was reading over the standard of care thing, at that time, having patients call in, if they didn't get it, it was I think our assumption was, though they didn't get it, they don't care. And then Micah came with that recommendation. I want to say roughly 2000. Can you guys help me with this? Do you remember 2015, 2016? That's when we had this implemented in our computer system. So
once you get the lab results back, how does that information get transmitted to
So if it's something significant, serious, so say like I've got a super high SED rate or something that would be a concern to a child, I will personally call them back. If there's something a test that needs to be done, or, I need to send you for an ultrasound, I typically will make those calls, or I have triage nurses that are very eloquent, that if it's minor procedures, we'll do. Otherwise, MAs can call back the normal stuff.
But someone will call.
Oh, yeah.
Or the patient can do the portal.
Portal, yes.
I want to ask you a couple of questions. I'm a primary care doc.
Sure.
And so did you do a rectal exam on this patient at all?
No, I did not. And
why not? Why not?
Right. Well, in
the age group.
Yeah. Well, over 70, those recommendations,
But just a regular rectal exam.
Right. At the time when I saw him for the suprapubic pain and so on, I may have discussed it with him. I may have said, let's do a rectal exam. He may have declined. I don't know. I've had patients decline rectal exams. When I saw him again for the follow-up saying your PSA is elevated, I knew he was going to go to a urologist. It wouldn't have changed my treatment, at all. I was going to give him a referral to urology.
Doctor, you're a primary care doc.
Yeah, I agree.
You're supposed to do global care. And so, not once have I ever heard you so far even say that you're sorry that what happened with the patient. And so, let me finish. Let me finish. And so, we're here to, especially I think being osteopathic physicians, for our med students, we're here to take care of the whole patient. So I see that I would have done a rectal exam on this guy. I probably would have been checking that PSA. I know it was slightly elevated then, and maybe it wouldn't have run off alarm bells, but clearly I would have, had him come back. Could it have just been a prostate infection or prostatitis? Sure, it could have been. But we don't know that one way or the other. Yeah, I know about the guidelines and so forth that are out there. And so still, the PSA is our best probably indicator if you talk to a urologist of how we diagnose prostate cancer.
Absolutely.
So we know that in men, there is a higher propensity for that. And so I'm going to just say, I do rectal exams on patients that's appropriate, looking for blood in the stool, feeling for any lesions that are in the rectum, those types of things, to see if the prostate's enlarged, is it symmetrical. That's our job as primary care docs.
I completely agree with you.
Okay. So I'm trying to say, I feel that you did deviate from the standard of care. I really do. And I don't think that you can't say that, unfortunately this was aggressive in an older individual. And it did happen. Would there have been an outcome that was different? We probably not, but he probably could have gotten into care quicker. As for referrals, I'm going to tell you, when I see a PSA that's like that, I don't care if they're 80, I'm going to have them sit in my office and have my referral clerk say, we've got an appointment for you right now, okay? Whether it be next week or in 2 weeks, I want that in my head to be known that that patient is taken care of. I understand you're in Sierra Vista. It may be more difficult in a more rural-type setting, but I'm going to tell you, those are the things that make me concerned about this case. So, I don't know, Dr. Erbstrasser, you're primary caregiver, just like me. I don't know if there's any other things that brought it to mind that are here. I understand about paper charts, paper and getting those things done. But I do think there was a deviation here. Okay, go ahead, Dr. Strasser.
Yeah, I agree with everything you said, Dr. Cunningham. I mean, I'm kind of the old school like you, and the two tests you do is a DRE and you do a PSA. Those are your two best indicators, and I'll tell you why. I've had people who have had normal PSAs, but I feel a nodule on their prostate. And guess what? They got prostate cancer. If I didn't do the DRE, okay, I miss it.
Absolutely.
Okay. The other thing here, I think when it was at 12, I mean, bing, red light, not repeated in a month, repeated next day, do the exam.
Come back in a week.
Yeah, I mean.
Justin, can you arm off with my computer?
Yeah, my whole system.
So
went down.
I just find that
went
part
down
of it.
too.
Don't always listen to those guidelines like that.
We're here as physicians. And I'm going to tell you that. Go ahead. I'm sorry.
So I'm just, everybody's 77 years old. Well, my father-in-law died of prostate cancer, metastatic, and his last 2 years of his life was in severe pain. Okay, so you say, he's 77, so what? No.
Right.
He's a human being.
Absolutely. Yeah.
And he needs to be treated with that kind of respect. I don't like seeing age being the cutoff for doing, routine stuff. Certain things, yes, as long as you communicate with the patient. So that's what I have to say.
Yeah. Go ahead, Doctor.
And I'm in complete agreement with what you're telling me. And again, I can't say for certainty if I had the discussion with the patient or not. I do rectal exams on patients. I absolutely do. But I do ask them, do you want me to do a rectal exam or do you want me to just do a PSA? And we talk about it. And many times.
I don't think it's their decision. If they say to you, no, I refuse a rectal exam, then document that.
Exactly.
Don't ask them, do you want one? Who's going to raise their hand?
No one's going to raise their hand. No, I agree. And if that were the situation, I should have documented that. That's exactly right.
We're going to do a rectal exam. It's
exactly.
Like if I had to do every physical on the boys, it's like, do you want to check you for hernia?
Exactly.
They're like, no. I'm like, it's not the best part of my day either, but we're going to get through it.
Okay. Exactly.
Any other questions from board members?
No.
All right. I'm going to make a motion for a letter of non-disciplinary concern for failure to diagnose prostate cancer.
Let me try this.
Can I have a second? I have a second from Dr. Madam. Any discussion before we vote? And can I have a roll call, please?
Yes. Mr. Berg.
Aye.
Dr. Speakerman.
Aye.
Dr. Madam.
Aye.
Dr. Erbstrasser.
Yes.
Mr. Lando.
Aye.
Dr. Cunningham.
Yes. Please do rectal exams, please, doctor.
Absolutely.
Okay? And also, I'd be more aggressive on your PSAs and also look at your referral process in your office.
I certainly will.
Thank you.
Thank you.
Safe travels back.
Thank you.
I'm frozen here.
Oh, sorry. Mine's back on. It's back on.
Yours back on?
Yeah, mine's back on.
I'm frozen.
Hey, Doug, do you want to do one more?
Yeah, I'm gonna see. Well, I don't know. Do you want to try? You guys want to try and do one more, or do you guys want to go?
Because I have to go. Because I did.
It just says the network went down.
Oh, is that it? Okay.
Yeah, the network did go down. Yeah.
Yeah, I can't get back on. I'm
going to have to reboot mine.
Should we go? Should we break for lunch then and be back?
Just got a closed session.
But honestly,
I think I can log
Yeah, it went down.
Network just go down again?
yeah, just mine just did.
Yeah. I'll tell you, why don't we do this? Let's break for lunch.
Yes, we can fix the IT problem.
And then let's try and be back here. Do you want to try and start back at 1:45? Is that okay with everybody?
Yeah, Doug, I just have to.
I know you can't be here.
I can hear. Is there any case that we need that would be good for me?
We're good. Thank you. Okay. Thank you. So, you guys, we're going to go ahead. We're going to break. We're back in session for the afternoon. The next case that we're going to call is DO-17-0207A, Christopher Lynch Marsh, DO. Dr. Marsh, can you come forward? Have a seat right there, sir. One more on this side.
Sure.
Yeah. Perfect. Yeah. Perfect.
I've been asked to remind everyone not to speak over one another for the court reporter's sake.
Thank you for that reminder. And can you swear in Dr. Marsh for us, please?
I do.
Dr. Marsh. And then we have new people in the back. Can you just tell us about your training briefly and also the type of practice you have now?
Yeah, I finished medical school in the California school in '88 and did my postgraduate work in Dayton, Ohio at Grandview, and became board certified in family practice in 1996. I practice in a large multi-specialty group in Tucson out of Northwest Allied.
Okay. Thank you. Dr. Pry, I believe this was yours that you wanted to go over with us.
This case came before the board previously. It was an inappropriate prescribing case, and the board, I did a chart review on it also. Deviation from the standard of care for the original case was that there was only one urine drug screen performed, and it was inconsistent with his stated medications and positive for alcohol. The patient admitted to alcohol use for his anxiety, but no urine drug screen was performed until after 2013, which was when he agreed to discontinue alcohol. Dr. Marsh prescribed a rather large amount of opioids for the patient. No other laboratory was performed other than clotting studies. There's no documentation of a consult with any specialist. He was not referred to a pain management specialist or addictionologist. There was no pharmacy audit done. He prescribed 2 benzodiazepines at the same time. He prescribed opioids with benzodiazepines. He prescribed 2 short-acting opioids at the same time. And there was no preventative care performed, and he did not use a function-based approach. Then I did a chart review, and that also there were several concerns associated with that. The board, at the time of the last board meeting, the last time that he was here, asked Dr. Marsh to go to PACE for an evaluation of his prescribing. In the deviations for the standard of care that I found in that case is there were several patients in which no previous medical records were reviewed. In one patient, there was no controlled substance agreement signed. There was no urine drug screens performed. In several cases out of the 10, then there was several in which the urine drug screen was inconsistent, but there was no mention of it in the progress note. He did prescribe opioids and benzos at the same time to a patient with sleep apnea. There was no pharmacy audit documented in any of these cases, and he prescribed a rather large dose of opioids to patient LS, and there was no EKG performed prior to initiating methadone in patient LS. And Justin, did you want to speak to?
Yep. At the last board meeting, the board reviewed the CME that was completed and performed at PACE, and the board determined that that was acceptable in lieu of attending the PACE evaluation. So the reason that we're back here today is to deal with the underlying case and make a determination on that.
To resolve the case. Mm-hmm. Just for, because I'm not sure all the same board members were here from last time, just give us an update on your current, how you're dealing with pain management and so forth. I remember from last time, but I don't think everybody else does.
Yeah. Basically, the patient population that I had for 28 years,
I've referred anybody on long-acting opiates to a chronic pain doctor. I don't think I have but one person on a benzodiazepine with an opiate, and I believe they've been referred to psychiatry. If they're on short-acting opiates, we do a DEA scan, a patient questionnaire, and appropriate urine drug screening based on the risk of the patient.
Okay. Any questions from board members? Okay. Jerry, did you have any questions at all?
No, not it. So where...
So we need to resolve the case. That's what we're here.
So if I understood right, the CME covered the case?
Correct. Yeah, we went through that last time.
Okay.
We did that with him.
So the question is whether to move to disciplinary action.
I'm going to tell you, I think I'm satisfied with the doctor. I do believe he has learned from this. We have had other physicians before this board that have had other opioid prescribing issues, and I think that he is one, Dr. Marsh, that has taken this to heart. He has changed his practice completely, and how he practices medicine for pain management. And so at this point, I don't know if there's a whole lot more else to do. I would be happy. I'm not sure how other board members feel. I think a letter of concern would probably be
there needs to be some documentation.
I agree. I think a letter of concern would be appropriate for this. I don't know. I just don't know how other board members feel.
I would like to make a motion for a non-disciplinary letter of concern for his prior prescribing practices.
Of opioid prescribing and slash benzodiazepines. Okay. I have a motion from Dr. Maiden. Can I have a second? Second from Mr. Berg. Any discussion before we vote? Can I have a roll call, please?
Yes. Mr. Berg?
Yes.
Dr. Speakerman is absent. Dr. Maiden?
Aye.
Dr. Erbstrasser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes. Thank you, Dr. March. Good luck to you. Thank you for coming in.
Appreciate it.
Yeah. Keep up the good work, okay?
Thank you.
All right. Next case is G, DO-18-0098A, Robert Ian Marouk, DO license number 3583. Dr. Marouk? Dr. Marouk, is he in the audience?
He is not signed in.
He is not signed in. So, Gene, this is his second no-show, so can we refer this then? Tell me what we need to do. Formal hearing?
Yes, if he does not want to participate in this, either dismiss it or move to formal hearing.
So I would make a motion that we move this case to formal hearing for the doctor's failure to, he cannot be regulated and has failed to appear on 2 occasions for this case. Do I need to say anything else, Jean?
The underlying case, the reason he has the option not to appear at this hearing, so that's we don't refer it to formal hearing because he failed to appear.
So I'll withdraw that part from my motion then about him not showing up, but his.
We just want to refer it to.
Just refer to formal hearing. Do I have to say anything about any of the allegations or no? Or
no, for the reasons that are stated in the outside medical consultant's report.
For the reasons that are stated in the outside medical consultant's report.
And do we need
could you inform me, give me some direction what you seek at formal hearing in terms of discipline?
I would like to see a revocation. Okay.
Still second.
Second. Any discussion from any other board members? Is that good for you, Gene?
Yes.
All right. So let's have a roll call then, please.
Okay. Mr. Berg?
Aye.
Dr. Maiden?
Aye.
Dr. Erbstrasser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes.
Okay.
All right. That completes our morning investigative hearings that we finished up in the afternoon. Next, we're going to go on to, do we need to get any licensing person? Do they got a flight to catch or not?
The only one that I think might be is Dr. Welly, but I wasn't sure if he was back at the lunch.
Okay. So we'll go ahead and start with the consideration and action and compliance of board orders, okay? So the first one is A, DO-18-0158A, and also DO-18-0152A, Jeffrey Burrell Bushman, via license number 2338. Dr. Bushman, can you come forward, please? Welcome. We need to swear him in for these.
This is just compliance, so
okay.
no, there's no.
So I know. All right. You want to go ahead and review it? I'm sorry, what?
I'll have Dr.
Are we
Prob.
finished with the court reporting?
Yes.
So
You're all set after we got lectured.
It's a reminder for next time.
Please remind me for next time. I'm 39 years old, remember that.
Yes.
That's true. Justin, do you want to go ahead and review us on this, please?
I'll have Dr. Prob review this.
Dr. Prob.
Both of these cases involved inappropriate prescribing, and the board ordered Dr. Bushman to attend the PACE for an evaluation of his opioid prescribing. It was ordered on April 18th, 2019. And I believe that Dr. Bushman may have signed up for the opioid prescribing course inadvertently, thinking that that would be what the board had ordered. But he did receive this board order, and it's pretty clear from the order that that's not what was ordered.
Dr. Bushman, what do you have to say?
I received a notice that what I signed up for was correct, and then a few weeks before I was going to the course, I got a call from Justin saying, what about an evaluation? Call this person. So I called, and I said, we don't really have anything that fits that description. I read it straight off what was asked for, and she says, we don't have such a thing. We have a course to an evaluation to see if a doctor is impaired or something like that, but an evaluation of prescribing, we don't have such a thing. And at the course I went to, every single doctor there was sent by their state board for prescribing problems, so I felt I was in the right place.
I'm not really sure exactly what happened in Dr. Bushman's case. I did call PACE myself and asked them, and spoke to the person that does the scheduling, and she said that they definitely still have that course. I mean, we've sent many people we've sent many people for this evaluation, and she said they still offer that evaluation. I'm not sure what you were told when you called, because maybe you spoke to someone, I'm sure you spoke to someone else, but they definitely do still offer the evaluation.
And aren't they supposed to get approval for the course or the evaluations they go to with the executive director before they go?
So he did email me about the course, and he asked if this was an acceptable course, which we did approve as it was acceptable for the CME required for renewal. It was not the evaluation that he was required to take.
Okay.
And I did try to clarify that with him on the phone.
Did you so you understood that? Did you understand what he just said? It was okay for CME, but not for the evaluation that we wanted. Okay.
Sounds like there was a miscommunication.
Yeah, sounds like there was a miscommunication.
Well, often what happens is normally when we send people to PACE, we never know exactly when they're going to make contact with PACE. So what normally happens is they call, they schedule it, or they make the contact. Then PACE will contact us and ask us for information about what we want. In this case, we didn't get anything from PACE because they didn't realize, he wasn't scheduled for the correct thing is the problem.
Tell me about your prescribing patterns now, doctor.
I don't prescribe any opioids at this time. I have a restriction on my license for that.
Right, I know that.
Yeah. And
are you wanting to prescribe in the future? Is that what you're wanting to do, or no?
Actually, as far as chronic pain management, I just do not deal with that again.
Okay. Have you made any changes other than you can't prescribe? Have you done anything else with your practice or how you practice regarding referrals of patients to pain management, things like that?
Definitely. And I wish I'd have taken this course 10 years ago. I understand the rationale behind what's going on now. And
do you think you had deficits before?
I do. I admit I made errors. I did.
Okay.
I was well on my way to getting in compliance with the guidelines before I even came and met with you all. But yeah, I had made plenty of errors.
Okay. How do other board members feel? Do you still want to have an evaluation of him still?
I think if Dr. Bushman's going to go back to prescribing, I think we should.
Agreed.
Yep. Are you going to go back to prescribing pain medications? Because if you are, then we really feel this board wants to then send you for an evaluation.
I'd be glad not to prescribe pain medicine ever.
So if that's an agreement, would the board be satisfied with what he has taken so far?
Yeah.
I got a question. I mean, so he has a restriction on his license now.
Correct.
So are we going to maintain that restriction?
Sorry?
We're going to maintain that restriction.
No, I don't think we'll. I don't think we'll continue the restriction. Jean, go ahead. I see that look. Okay.
No, if you have a question, but the restriction that's currently is an interim practice restriction.
It's just interim for at this point. So he could possibly get his DEA license back after this. But he's saying to us now that he doesn't want to prescribe pain management, even if he gets it back. Is that true, doctor?
That's correct.
You don't want to do any pain management
so
whatsoever.
Let me ask you this. You're in family practice, right? And you get a patient that comes in and they fractured their wrist and you bandage it up and you're going to send an orthopedist, but they're in severe pain. What would you do?
Well, if I'm not going to ever prescribe it, I'll have to refer to someone else in the office. But I had envisioned not doing chronic pain management anymore, but in cases like
well,
that.
Well, that's the thing you got to think about. Someone comes in with pyelonephritis or something, you're going to prescribe it for 7 to 10 days, probably at the most.
Well, first let's deal with this first. Is it do you guys want to accept as the acceptable that he went for that course? If that's okay.
What is that course?
What is the course?
Oh, it's the PACE.
The PACE prescribing course.
Prescribing course. That's what a lot of the docs go through.
That's what he attended?
That's what he attended.
Versus the practice assessment.
Where practice assessment is where they put him through practice scenarios of managing chronic pain management patients of chronic pain. How do you prescribe all those types of things?
I don't think he's going to do the chronic pain thing.
I don't either.
Okay.
I guess that's fine.
I'm okay with it, and I think that he has learned by this. There were some beyond the standard of care in this practice, but I think that has changed now. Clearly, because we restricted him too. But I think that he says he's learned from it. So again, it's kind of like what we had dealt with earlier. So we need to.
Close case.
So, we can't do that now. It's got to go to. So first, we accept what the PACE was. So we need a motion for that. So if I can have a motion that his PACE prescribing course is acceptable in place of the evaluation, I need a motion for that in a second.
Finding him in compliance with the interim order.
Findings for compliance with the interim order. So I have, someone made a motion.
So moved.
Mr. Burge, can I have a second?
Second.
Dr. Madam. And then all in favor signify by saying aye.
Aye.
Opposed, same sign. So then we move the case to investigative hearing at our next board meeting, correct?
Correct.
That's just how we have to do these, okay? And we'll go from there.
That's right. This is just a review.
Okay? Mm-hmm. All right. We'll see you. When do you think we'll put it on the schedule?
October.
We'll see you in October then, and then we'll resolve these cases then, okay?
Oh,
but the interim is still in effect, okay?
Yeah.
Until we see you in October, okay? All we did today was say what you did with the PACE course that you took satisfies what we wanted on the board order, okay? Okay, sound good?
So I still don't have prescribing privileges.
Correct, you don't. No, correct. All right, until we see you in October when we resolve the case. All right?
Okay.
All right, thank you, sir.
Thank you.
Okay.
I'm a little confused on that one.
It is confusing.
It's okay.
All right, next case is DO-18-0014A, Roy Niels Skousen, DO, license number 2214. Dr. Skousen, welcome.
Back.
You flew all the way back from Oklahoma, did you?
Yeah, this is third time.
Hope you're getting frequent flyer miles.
Yes,
If you can sit on
Southwest
this,
has good-
sit on this side for us. Yeah,
Southwest has
because
good
that
flights.
hole's in
That's
the way.
good.
All right. So, who wants to review this case with us for compliances?
Oh,
Or that's just for
the
compliance?
compliance,
Yeah.
I guess it should be Dr. Prowl.
I can.
Probably going to have to go into executive session
Okay.
to do that.
So, for medical...
Medical
All right.
information.
So can I have a motion to go into executive session for medical information? So moved by Dr. Maynard. I have a second by by Mr. Burge. I'm going to make you doctor. All in favor, signify by saying aye.
Aye.
All opposed, same sign. So unfortunately, all of you guys are going to have to step out of the room, back through those doors. Please take your belongings with you. We're back out of executive session for obtaining medical information. Are we back on? Okay.
Yeah.
We're back on. Can I have a motion?
Yeah, I'll go ahead and move that. Move that we follow our discussion. Move the discussion that was had in executive session.
Can I have a second?
Second.
Second. All in favor signify by saying aye.
Aye.
All opposed, same sign. Dr. Skousen, fly safely back, okay?
Okay.
All right. Good luck to you, okay? All right. Next is C, DO-17-0268, and also DO-17-02698, Brian Samuel Page, DO, license number 3416. Dr. Page, can you come forward? Please have a seat there. Thank you. And can you introduce your counsel with you as well?
This is Robert Milligan. He's my attorney.
Okay. And I understand you have new counsel now, so all right. And I believe, who's going to bring us up to date? It's you, Justin, right, on this one?
So as directed by Mr. Landau at the last meeting, this is attempt to be a status conference just to bring everybody onto the same page as where we're at. We have received everything that we have requested. The timeliness was a concern, which is why the
How many months did it take? I'd like to just know that.
I could get you that calculation.
Okay. It's been over 6 months, correct?
Correct.
I think it was closer to 8 or 9, as I recall.
But we do have everything that we need at this point. So this was a chance for the doctor and his new attorney to come in and address any of the board's concerns regarding the 2 cases.
Okay. We're not going through the cases.
No.
It was just getting the information. I think the frustration, Dr. Page, is that I know that you got a new attorney. We could not get the information out of your office, and so that we had requested over and over. I think Dr. Praw had documented how many times that you had made requests. So many you can't count. Okay, so that was the reason why we made you show up here today, to make sure we have everything. Is there anything that you want to add? Did you want to say?
Maybe Dr. Page or Mr. Mulligan can address why we've had to pull a lot of teeth to obtain the information that we need.
Thank you, President Cunningham and members of the board. First, I would like to take this opportunity to apologize for the way communications have been handled between my office and the board. I take absolute responsibility for any miscommunications, delays, etc. Because of this, I wasted your time and caused this case to be delayed farther than it should have been. The board. Basically, I over-delegated. I should have been more hands-on, and I did not spend enough attention to the process, clearly.
Okay. Go ahead. Did you have a question?
Yeah. I appreciate the fact that you take responsibility for it and you're apologizing. But why?
It's my belief that a lot of the issues were related to my attorney. My office would present information to my attorney, and then it wouldn't get sent to the board, and I lost confidence with my attorney, and that's why I hired a new attorney.
Okay. I don't think there's any. Do you have anything, Justin? No. When are we setting these cases to be heard? I thought we were doing it in September. Are they still on the agenda for September?
They are set for September.
So we'll see you then in September then, okay, to hear these cases. I appreciate you coming here, giving us an explanation. I'm sorry it came down to this, because I think this is a waste of your time too. I really do. You've got other things to do better than being here on Saturday with us. But at least we have all the information now. Okay, go ahead.
Dr. Cunningham, if there are any additional requests or if anything that you thought you had is missing or inadequate, please just let me know, and I'll get it to you pronto. Those are my directions from Dr. Page, and I'll make sure that happens, okay?
Thank you.
Thank you so much.
Thank you so much.
All right. Have a good afternoon, you guys. Next, we're going to go to applications, number 9, reviewing consideration and reviewing applications for licensure. Is there anyone on here first that we should hear first for people that have to catch planes, or just start down the way?
Start down the way.
So the first one is DO-19-0114A, Mark Thomas Hash, Dr. Hash, can you come forward, please? You've been sitting too close to Mr. Landau. You got his cold now.
You better not.
Okay, you just have a seat right there. Thank you. Do you want to review this case for us, Justin? Or is this John? This is John.
I'll have John do it. Thank you.
Okay.
Okay. Mark Thomas Hatch applied for an Arizona osteopathic license on October 29, 2018. He meets the education, training, and examination requirements for licensure. Dr. Hash disclosed yes answers on the professional conduct history portion regarding being arrested and charged with any felony or misdemeanor, and a second yes answer regarding being placed on probation or having his privileges restricted, suspended, terminated, or any other adverse action against his participation. Regarding the first yes answer relating to the criminal charges, Dr. Hash reported that in 2008, while working as an independent contractor in a privately owned clinic, the owner of the clinic used his DEA license and Florida medical license to order controlled substances, sign for medications delivered by UPS, pay for the medication on the owner's business bank account, and dispense medication to patients Dr. Hash had never seen. The owner also had obtained a Florida health care clinic establishment permit as was required by the Florida Department of Health. Dr. Hash advised he did not discover this was occurring until just prior to his arrest regarding the incidents. He was arrested for facilitation, which also involved several Florida law enforcement officers in obtaining controlled substances by fraud. This had been occurring without Dr. Hash's knowledge, perpetrated by the owner of the clinic. After a thorough investigation by the state of Florida, the charges against Dr. Hatch were dropped after the owner and one of her employees admitted to fraud, including the unauthorized use of Dr. Hatch's signature, and they were also convicted of practicing health care without a license. Dr. Hash reports that at no time were his medical or DEA license restricted, nor were his hospital privileges restricted. Dr. Hash provided proof of the dismissal of the criminal charges by the court. Dr. Hash also explained what he described as an illegal arrest by the state of Florida related to a custody battle involving his sons in June of 2003. He became a single father with full custody of his sons. Their mother was originally diagnosed with mental illness in 1999, and since that time became increasingly violent and impulsive, which he claims included ambushing them with loaded guns, jumping out of moving cars, and overdosing on benzodiazepines and physical abuse. She was committed twice to a psychiatric facility, and her psychiatrist felt that she was impulsive and dangerous. Regarding the yes answer, regarding being terminated from residency program in July 1st of 1992, his wife and himself began training at the Wright State University School of Medicine in Dayton, Ohio. He began training in the Emergency Medicine Residency American Osteopathic Association internship with his then wife, transferred into a second year of medical school there. In August of 1992, they separated, filed for divorce, and she quickly married one of their medical students. The divorce was emotionally devastating to Dr. Hatch and greatly distracted him from his academics. Consequently, he was dismissed from the residency in December of 1993. However, in January 1994, he began his PGY2 year in family medicine at Spartanburg Regional Medical Center in Spartanburg, South Carolina, part of the Medical University of South Carolina organization. He left the Wright State University in Dayton, Ohio, for a new environment free of drama and chaos, which did wonders for his ability to focus on himself and his career. He successfully graduated from the family medicine residency in 1996. Lastly, Dr. Hatch did not check the box on his application regarding disciplinary action, but he did provide a written explanation and documentation with his application. He explained that in May 2000, while serving as a U.S. Army major and brigade surgeon with an airborne brigade.
You need to hold off on that because it's got medical information.
Okay.
So let's hold off on that. The only other question that I'm not so interested in the stuff that we've talked about. The things I'm more interested in are the things we're coming up on. Do we need to go into executive session for medical information for these two things? The ones that he's talked about in the next paragraph, Gene?
I would agree.
Okay. So I make a motion to go into executive session for medical information from the doctor. Can I have a second? Second from Mr. Landau. All in favor signify by saying aye.
Aye.
All opposed, same sign. Back out of executive session for obtaining medical information from the doctor. And so tell us again where you're going to be a hospitalist, is that correct?
I'm applying for hospitalist jobs, primary care jobs.
You've been offered one. Where's the one you've been offered?
In Grand Canyon. There's a clinic there. Sounds quite fascinating.
Huh, Grand Canyon.
Just got back from there.
There's a clinic up there. I didn't know there was a clinic.
Yeah, there is.
Very interesting, yeah.
Oh, that'd be a blast.
Oh, no.
Is it full year?
I believe it is, but I had to put them on hold because I said I don't have a license.
Okay. Any questions from other board members? Any questions, Gene? Anything? Okay. Can I have a motion?
I'd like to make a motion to grant an unrestricted license.
I have a motion to give an unrestricted license from Dr. Madam. Can I have a second?
Second.
Second from Mr. Burge. All in favor signify by saying aye.
Aye.
Aye. All opposed, same sign. Good luck to you, doctor. Thank you for coming down today. It wasn't that bad, was it?
No, thank you all.
But don't tell that to the students back there, okay?
I won't.
You want to scare them.
Easier than January in the Grand Canyon.
Good luck to you up there. All right.
Thank you.
Next one is BDO-19-0143A, Donald W. Brown. Dr. Brown, can you come? Dr. Brown, please come forward. Please have a seat right there. Welcome. Thank you. All right. And then, again, I think this is yours too, John.
Yes, sir.
Okay. Oops.
Donald Brown Jr. applied for an Arizona osteopathic license on September 7th, 2018. He meets the education, training, and examination requirements for licensure. Dr. Brown disclosed 3 yes answers under the professional conduct history portion of the application. The first yes answer is regarding having a DEA permit or prescription permit being denied, restricted, suspended, lost, or other action against it. The second yes answer is regarding any awards or payments made on his behalf to resolve a civil suit or malpractice claim. And the third yes answer pertains to having been diagnosed or developing.
We don't get what the diagnosis is, okay?
Okay. Regarding the first yes answer relating to Dr. Brown's DEA license, he advised that his DEA license was temporarily restricted because of his revocation from relocation to Michigan to Arizona. He attached an email correspondence from the DEA diversion unit, which indicated that he would be granted a new license when he secures an Arizona osteopathic license. Regarding the second yes answer relating to malpractice claims, Dr. Brown indicated there were 2. Dr. Brown advised the first was on March 25th, 1996, when Dr. Brown administered anesthesia to the claimant. Post-operatively, the claimant was chewing ice in the recovery room and broke a tooth. The award was for the tooth to be repaired. The second claim came as a result of an incident on November 20th of 2000. The complainant presented to her dentist that she suffered 2 chipped front teeth during an intubation process for a radial mastectomy. The award was for 75% of the claimant's dental bill, half of which was paid by Dr. Brown's insurance, and the other half by the insurance of the CRNA. Regarding the third answer is medical issues.
You want to go into? Yeah. So I'm sorry again, you guys. Step back out there, and we're going to go. Can I have a motion to go into session for medical? So move. Can I have a second? All in favor, signal by saying aye.
Aye.
Okay. session for attaining medical information. So you haven't been in practice then for how many years? About 8 years?
Say 2008, ballpark.
Okay, a little over 10 years. Okay, over 10 years. What are the questions other board members have? I know you were wanting a unrestricted license for prescribing as well.
Given that Walgreens, CVS, et cetera, are pretty good about giving somebody a short supply of a medication if there's a problem, they lost it, they forgot it, whatever, my prescribing is going to be probably negligible.
Because you said you wanted to prescribe for people.
Only if, say somebody is visiting from out of state, they forgot their blood pressure pill or whatever, and Walgreens or CVS cannot resolve it, then I would try and help in any way I could.
You're talking like
I'm not going to be doling out narcotics or...
are you talking like a family member or something like that?
Visitor, old neighbor. I tend to not want to treat family.
I don't know.
In any way, shape, or form.
How do other board members feel about that?
So what's the idea? Is that going to be the only part of your practice, so to speak?
I can't hear you.
Is that going to be the only part of your practice?
That would be the only... I don't practice medicine in any way, shape, or form.
That's what I was trying to reconcile.
I do not practice. I have no intention of practicing. I need a medical license for my job with United Healthcare.
I'm going to tell you, I'd feel uncomfortable giving you that unrestricted license only from the fact that you haven't been in practice for a long time. And then if somebody's forgotten their medication, I get it, but if you don't have expertise on some of the newer medications that are out there or those things, I would feel uncomfortable with you filling those. We don't have any way to monitor that. I'm going to tell you I would only, and if you're going to be doing stuff for United Healthcare, I feel more comfortable for an administrative license, but not an unrestricted license. I don't know how other board members feel.
Yeah, how are you going to know what to prescribe?
The only thing I would do is, say somebody's got a script at Walgreens for their hypertension medication, I would...
How's he going to maintain records and all that?
Either they have a prescription number or something. I'm not going to say, the PDR on the computer and look up a blood pressure med and, play what's the right medication, what's the right dose. It would be to get them whatever medication they're on for a few days.
Yeah, the thing is, once you prescribe, you're responsible for the prescription and knowing what to prescribe and in what dosage. It's not just, well, if this doctor did it, then it's okay to do. Once you put your name on it, you're making an independent determination.
Right. And access to medical records.
Yeah, you're not practicing, you're not looking at, as Dr. Cunningham said, you're not looking at records. I think by giving you an unrestricted license, we're putting you in a very difficult situation. I think you're better off taking Dr. Cunningham's suggestion on the administrative license.
All right, so...
That way nobody can never come up to you and say, hey, can you do this for me? And you're put in an awkward position to have to say yes or no. You're just not part of your deal.
Yeah. Then if some doctor prescribes a medication and then you prescribe it because that other doctor did and something happens because of maybe the original prescription, then you're liable. You may be very well liable. So.
All right, so the administrative would meet my employer needs.
Absolutely.
And then...
Yep. We've done it many times.
I would just assume not intervene, and again, that's why I put very limited.
Yeah, you can't do that.
So if you're okay with that, then could I have a motion?
Also move.
I have a motion for an administrative license from Mr. Landau. Can I have a second? Second from Dr. Madam. All in favor, signify by saying aye.
Aye.
All opposed, same sign. Thank you so much. Good luck to you, Doctor.
Thank you.
All right, welcome to Arizona.
In Michigan, I do not miss the Titans.
No, I still have a lot of relatives back there. I don't blame you. He went to go get a drink. Go get a Diet Coke. He'll be right back. But I'm going to call the next case up, okay? All right. Let me get my computer up. All right. Next one is D, DO-19-0, 139A, Farrell Lee Roseberry, DO. Dr. Roseberry, are you here? Welcome, Dr. Roseberry. Please come and have a seat up here. Thank you for coming. Whose is it? Are you going to do this one, John, too? Or is it Justin? Okay.
I can do
it. Hang on just a minute till Mr. Landau gets back, okay?
Skip over one.
Did I skip one?
C. Charlie.
Did I skip C? You know, I told her I'm getting older.
Just to make sure I wasn't going crazy.
Okay.
You still might be going crazy.
Fair.
Sorry about that.
Yeah, you
Thank you
Davis.
very much.
I thought so.
Just make sure you
too.
come back to it.
Dr. Davis, I'll be right with you in just a minute. I apologize.
I thought so.
It's my ear. I can't multitask. That's the problem. I was trying to ask my mom on the phone on a text.
Multitasking, just the way
How to
to
respond to
create errors
mom.
more efficiently, right?
Okay.
I have the wrong advanced degree to operate. Thanks. My throat was killing me. This was.
Go ahead. Go ahead, Justin. You're all
Okay.
set. All right.
Dr. Rosenberry has applied for a PGT renewal of his training contract. He submitted a renewal that had a positive yes answer, that he was arrested for a incident involving his wife. It was not reported within the 10 days as required, and he provided a letter from the director explaining why that wasn't reported within 10 days, so the board can then address their concern with the reporting time frame as well as the event that occurred.
Do you care to comment on what's going on here, Doctor?
Immediately after the arrest, I informed both my program director and the optee, Lilia Wilson, about the arrest, and they both informed me that I would not need to inform the board at that time. So that was all. Because actually, I mentioned that specifically. That is this something that I need to inform the board about? And they both indicated I did not. So I was just going off of their expertise.
And so have we contacted that program director then too?
I have not spoken with him directly. I was drafting the letter providing clarification.
So for all your med students in the back, don't listen to your program director, okay? There may be an error. If you have a question, contact the board. I know it's kind of scary to contact the board, but I believe you, Justin is a very nice guy, and he will, if he doesn't know the answer, he'll find the answer, he'll run me down too. And if there's any question about reporting anything, report it, okay? So now, because this doctor here now, he's here before us because he didn't report, because he listened to his program director, okay? Any questions from board members?
Just one, if I could. The case was, as part of the case, you attended an anger management program, correct?
That's correct.
And the case was dismissed in part because you completed the program and in part because your wife did not want to pursue the charges. Is that correct?
That's my understanding.
Okay.
Any other questions from board members? Can I have a motion? Doesn't he have to have a, this is for a license, isn't it?
He would have to approve the renewal of his PGT part
for
year
approval
two.
of his PGT training certificate.
Okay, I make a motion to approve his PGE training
certificate. All right, so I have a motion from Dr. Erbstrasser. Do I have a second?
Second.
All in favor, signify by saying aye. All opposed, same sign. So, Doctor, every time you apply any state, you have to report this, okay?
I understand.
Okay, all right. So, and even probably hospital privileges, all those things you're going to have to do.
It's been, very complicated.
All right. Welcome. All right. Have a good afternoon. Thank you for coming.
Thank you.
Sir. All right.
You may be welcome.
All right. Let me go back to C. Philip M. Davis. Dr. Davis, can you come forward? I apologize for that, for going out of order. All right. This is yours then, Justin, or is this John's? This is again for a postgraduate training application.
Let me pull it. Okay. Dr. Davis has applied for PGT. He disclosed a yes answer on his application.
Okay.
The doctor was arrested for DUI that was pled down to a reckless driving. The board can deal with the underlying cause of the case, of the arrest.
Okay. Questions, Mr. Landau? Let me just caution you, he wrote all the DUI laws for the state of Arizona, okay?
Yeah, when I saw the reckless driving, I figured it was a DUI. It's, for the most part, how you get to a reckless driving. What happened on the DUI arrest?
I think it was like 7 years ago, and I was going, I think, like 65 in a work zone, which was 25, and the officer pulled me over. He said, "Had you been drinking?" I said, "I had a couple drinks with dinner." We did all the testing, and he said, "Okay, no driving until you go see the judge." I said, "Okay." The judge gave me the reckless driving paper and said, "You're good to go."
Did they have you blow or anything like that?
I did, and then they didn't tell me what it was or anything. He just said...
Because I didn't find it in here. You guys didn't find it, did you?
No.
I'm not following. I guess not following. But you issued a citation.
Yeah, the reckless driving citation that I gave you, that's the only thing that I got.
So he actually gave you he did not give you a DUI citation.
No.
Gave you reckless driving. How'd you get from where the officer stopped you to wherever you were going?
I had friends in the car with me. So then he took me, we did the testing. I went back to the station. I blew, and then they said, "Okay, go ahead. And then don't drive until you see the judge." And I said, "Okay."
My guess is the alcohol test was below the presumptive limit, and that's why they did that. Okay.
All right. Can I have a motion to grant a PG post-medical graduate training certificate?
So moved.
So moved from Dr. Madem. Second?
Second.
Dr. Erbswasser. All in favor signify by saying
aye.
Aye. All opposed, same sign. Thank you for coming down.
Thank
the
you.
reason I do that is for you guys. Remember that any drinking at all, you know what to do. Call Uber or Lyft, okay?
Even though they're not financially solvent.
All right.
Yo, you read that? Yeah. What was it? They may
What was that?
Uber is.
No, they're not financially solvent.
Oh, I didn't know
Very,
that.
very.
Oh, yeah, there's a spot right now.
All right, next is EDO-17-0235A, Scott Nicholas Welly. Dr. Welly, please have a seat there.
A bunch of people just gave a bunch of money. It's called an IPO.
Yeah. I know.
Welcome, Dr. Welly. Have a seat there.
Okay. Dr. Welly had previously applied for a license. The board had expressed some concern and wanted to have additional training completed by Dr. Welly prior to be issuing the license. Dr. Welly then withdrew his application, has subsequently completed the supervised training, has now submitted a new application and provided documentation of the supervised training. So the board can then review and determine if the training was acceptable for approving and issuing the license.
Tell us about your training.
I went and did a surgical critical care fellowship in the Bronx, New York, which time I did the 150 cases, in addition becoming now board certified in surgical critical care pending an AOA BOS meeting, whatever that is again. And have signed a contract with Valley Surgical acute care surgeons here in Phoenix. So just waiting to hopefully get my Arizona license back and start working here.
Any questions from other board members? I don't have any either. I remember because that was a few years ago that you were here, I think.
I think Dr. Pross had something.
It was roughly 18 months ago that I was here, and I had my Michigan license. And
Dr. Paul, did you have?
I was just going to ask: Are you an internist, so you'll work in the critical care unit for surgical patients, or are you a surgeon?
I'm a surgeon. So there are two ways you become a intensivist. You can either become pulmonary critical care, or you can become a surgical critical care. And so I'm board certified in surgical critical care.
Any other questions?
Are you glad you did the training?
Yeah.
We're glad you did it too. All right. Can I have a motion?
New York.
Yeah. Can I have a motion?
Also move for
unrestricted license.
Unrestricted license.
All right. Second, Dr. Maynham. All in favor signify by saying aye.
Aye.
All opposed, same sign. Welcome to the state of Arizona. Good job, doctor.
Thank you. Thank you.
All right.
And you'll like working for Valley.
Alicia's great.
Next is, so, what do you want to do 11 and get that over with, or no?
Is he here?
Dr. Forster, I believe, or Foster is signed in. Are you present? If you please come forward.
So, next is this is review and consideration action on the physician signed consent agreements. This is for DO-17-016A, Jameson Foster, DO license number 006198. Do you want to go through this? Is this yours, Justin?
Yes. Okay. So Dr. Foster is currently going through the disciplinary the complaint process and was issued a offer of consent agreement for the resolution of the two cases. That consent agreement was not signed in a standard time, so it was brought back before the board. The board then forwarded the complaints to the Office of Administrative Hearings for revocation. Subsequently, Dr. Foster has now submitted a renewal form and payment, as well as the signed consent agreement. The terms of the consent agreement are for, I believe it's a suspended license for a minimum of 3 years, and then he'd come back before the board to reinstate that license at the board's discretion. So the board can determine if they'd like to accept the signed consent agreement and rescind the direction to OA for the revocation. If not, the board can then let the OA recommendation stand.
When was he supposed to sign that? What was the date on that?
I believe it was sent to him in early February. He was supposed to have it signed by the end of March.
I remember that.
Yeah, I remember. Yeah.
What happened to you, doctor?
I didn't have the funds to pay for the fee, and I expressed that concern to my lawyer, and he just said, we'll try to sign it and get the funds as soon as possible. I told him it might take a little bit of time, and I didn't really hear back from him. I did save money and then contacted my lawyer and just submitted it because I never received a response from him.
So let me just tell you, the best thing in situations like this is contact the executive director, okay? Because we as the board thought you were just ignoring us, okay?
No, I was trying to run everything through my lawyer.
And so that's why we sent this, because remember, it was if you didn't sign it, we were going to send this to administrative law judge for revocation.
Yeah.
Remember?
Sorry.
Yeah, I have a question, though.
Yeah.
As those of you here this morning will tell, Mr. Myers and I sometimes don't see eye to eye, but he is a very, it kind of strikes me as strange that you would never hear from him. He's extremely competent and diligent.
All the correspondence run through his administrative assistant, and there was a period of 4 weeks where I did not hear back from him from my email. I have it all documented. I'm not. In no way was I trying to skirt the issue or blow you guys off. It was just a monetary.
So he's in compliance now. All we have to do is we're going to accept the consent. Yes, Gene, is that correct?
Yeah, and if you accept the consent agreement, then you want to rescind your motion to formal hearing.
Yeah. How do board members feel? I'm okay with that because then he's still his license is in suspension. We're still protecting the public, and so I don't have an issue with that.
Am I understanding? Just so we're clear. Oh, I'm sorry.
No, Gene was going to say something real quick.
Just, if that's the way you're going, you want to rescind the motion to formal hearing, accept the consent agreement, and grant his application for renewal.
Right.
So 3 things.
Just so we're clear on the consent agreement, the suspension is for a minimum of 3 years, and it's effective today or when sent? Effective today.
Effective the day it's signed.
Okay.
The day it's signed.
So it's effective today.
Well, I don't know if he's signing it today.
Or if you can sign it.
Signed it about a month.
He's already turned it in and it's signed. So.
Okay. When was it signed?
It was signed by him on May 18th, 2019.
Okay.
Over a month ago.
All right. Okay.
You want to make a motion?
Yeah, I'll.
Remember the first one to rescind the.
Yeah, I'll move we rescind the action the board previously taken where this case was referred to the Office of Administrative Hearings.
I have a motion. Do I have a second?
Second.
Second from Dr. Madam. All in favor signify by saying aye.
Aye.
All opposed, same sign. So next then is accept the consent agreement.
I'll move we accept the consent agreement dated May 18th, was it?
Yes.
May 18th, 2019.
I have a motion. Do I have a second?
Second.
Second from Dr. Erbstrasser. All in favor signify by saying aye. All opposed, same sign.
Aye.
And then last is the
Grant
his application.
an application for licensure. I move that we grant the Dr. Jameson's application for licensure subject to the consent agreement previously agreed upon.
I have a motion. Do I have a second? Second. Dr. Madam. All in favor signify by saying aye.
Aye.
All opposed, same sign.
Do roll call.
Good luck to you, Doctor.
We should have done a roll call on accepting the consent agreement because it involves
All
this.
right, let's do a roll call on accepting of this. We'll go back to the second motion. And so remember that motion is accepting the consent agreement. And Dr. Erbstrasser was the one who seconded it. Can I have a roll call, please?
Yes, Mr. Berg.
Aye.
Dr. Madam.
Aye.
Dr. Erbstrasser.
Yes.
Mr. Landau.
Aye.
Dr. Cunningham.
Yes. All right. Good luck to you, Doctor. I wish you the best and good luck to you, okay?
Appreciate it. Thank you again.
Is there any other positions or any other things we need to do?
That is everyone that I have signed in.
Then let's have the med students come forward. Come on up here, you guys. You come all right up in here. All right. Don't be nervous. Just come right on up here.
She's just.
It's a big crowd.
It's a big group, you guys. What'd you guys learn today?
Document.
Document. What else?
Here it is.
Sorry, what? So remember, we're pretty tough. Remember, if you're filling out those applications, it's your responsibility, guys. It's not your girlfriend, your boyfriend, your mother, okay, your attorney or your office manager. You're signing your name there, okay? So you make sure that's correct because we don't take very kindly to those things, okay? So make sure, that was the big thing I want you guys to learn about. Please fill out those applications correctly because you're going to be applying to a lot of places for residencies, insurance plans, different states, all of those things, okay? What else did you guys learn? Sorry? I'm sorry?
There's a lot of flexibility.
Oh, they're taxing.
Flexibility with who?
So you as a board have a lot of flexibility in determining kind of how you want to approach issues.
Sure.
And that ends up being very personally tailored to the position that you're interacting with in the situation. So referral to the board is not like an immediate consequence in any one direction, but that you take kind of everything into account.
Yeah, we're here to protect the public. We're all appointed by the governor here. And so, we're here to protect the public. But clearly, if we can rehabilitate a physician, we're going to do that. And we're trying to help. If they're, if they don't want to participate, you can see what we did with some earlier cases. We sent them for revocation. Okay? So, and that's a good thing that you saw. Anything else?
I just had a quick question regarding case DO8.
We can't comment about specific cases.
Oh,
Gene will actually.
Unless it's resolved.
Is that right? We can't do it.
Unless it's resolved.
I don't know which one it was.
But still, we're limited in what we could say as adjudicators.
Yeah. Yeah. Yes. Brian Friedman.
Oh, okay.
What do you want to ask about Dr. Friedman?
I understand that he was given a non-disciplinary action, but my understanding was what happens to the bill because the patient was still billed for the things that quote unquote.
That's something the insurance company is going to have to fight with Dr. Friedman.
Okay.
And they made no finding.
We made no finding about the billing issues. Sometimes we have to get in the middle of that, but I try and stay out of the rest. Let the insurance companies fight.
But no matter what our finding would be on an individual case, who's responsible for a bill is in a different forum.
Right. More of a superior court issue type thing.
It could be.
What other things did you guys learn?
Can I ask another question?
Sure.
So in regards to like the different kinds of letters, like censure, non-disciplinary, like all the different kinds of letters that you guys can send out, which ones of those are like publicly accessible, or you can like can find a record of those like certain kinds of records?
Do you want to do that, Jerry, or do you want me to do it?
Let's all the disciplinary action. Now, there's disciplinary and non-disciplinary action. A letter of concern is non-disciplinary, whereas a censure, an administrative warning, a suspension, and a revocation, and probation are all disciplinary.
And that goes to the National Data Reporting Bank, okay?
Right. Goes to the National Data Reporting Bank, to the Federation of State Medical Boards, and it's accessible on our website. Non-disciplinary, Gene, is not accessible, correct?
Letters of concern are not on the website.
Right.
But non-disciplinary orders are, but they're all maintained in the file. So if you wanted to come down and look at someone's file, you could see a letter of concern.
Okay. Yeah. Good question. Any other things that you learned? What did you guys learn about drinking?
Avoid it. A little bit.
Yeah. Some of the DUI laws are very strict.
Yes.
Thanks,
absolutely. I'm just telling you, if you have one drink, call Uber or Lyft or have somebody else drive for you. Don't take that risk. Because I want to tell you, if you get a DUI, it's going to follow you for the rest of your lives, okay? And if you have a substance abuse problem, alcohol, whatever it may be, or if you know of a friend that's in school with you now, this is the time to talk to him. And take care of it now. It may cost you a year in school, but take care of it now, because once you get into practice, I'm going to tell you, you come before us, it's not such a good thing. Now, Dr. Prosh is going to tell you about what we have, one program for that's confidential.
Yeah. So Arizona has the Osteopathic Board has a confidential treatment program that if someone self-reports to the board that they have a problem with alcohol or drugs, we will help you find treatment and help you get healthy again, and monitor you for whatever period of time is deemed necessary in order to make sure that you're safe to practice again before we release you. So it's sort of like a probation, only it's a confidential probation.
And self-report is done after you get a DUI, okay?
Yeah, self-report.
Oops, I got a DUI. I'm going to come talk to the board now. You still have to report it to the board, but it won't be in the confidential program.
Self-report is if you yourself report it, obviously, and if there's not been any patient harm or malpractice case or criminal activity related to it.
If you self-report, do you have to check yes on the history of treatment for mental health conditions on your form?
Yes, you do.
But that's confidential.
Those are confidential.
But you would still have to come ahead of the board and discuss it every time you renew your
license?
license?
Not necessarily. No. Not necessarily. You might, but if you did, it would be held in a it would be, you know how a lot of times we asked everybody to leave and it would be under
that's confidential.
But it's still required.
You still, yes.
It may.
Yes.
It may. It's up to the board, theoretically, whether or not you have to come before the board or the executive director grants the license. For the most part, probably would, but it's up to the board.
For instance, if you were, say, in training and you reported to us that you had a problem and we put you through the program, and then a few years later you needed to renew your license and you checked yes, we would remember who you were, and in those cases, and if everything was great, then you wouldn't have to come before the board again. It wouldn't, you know what I mean? But other boards you might have to. That's true.
Well,
That's true.
It varies.
Yeah.
It varies.
But even if you do, it's much preferable to the other alternatives. That you don't go through the confidential. Yeah.
Mm-hmm. Yeah.
Most boards have a confidential program.
Yeah. Jerry, you want to talk to them about the Federation and about all their
credentialing service,
licensure and service?
Yeah, you're starting your medical careers, and you're going to complete medical school, and then you're going to go into a residency. You're going to work at various hospitals. You might be a fellowship, and then you're going to go into practice, and you're going to apply for, say, here in Arizona, you're going to apply for a full unrestricted license. 15 years from now, And you might do some additional training. You might get board certified. Or 30 years from now, you may decide, shoot, I'm going to move to Vermont, and I've had it with this 117-degree temperature. And you're going to apply. If you don't go through the Interstate Medical License Compact Commission, you're going to have to apply for a license. They're going to ask you every place you worked and every place you were participated in a program from the day you started medical school. And the state bar does the same thing for attorneys. And more credit to you if you remember all of that stuff. And that is why many people, of course, don't, and that's one big reason for delay in getting licensure. So what we do is establish or use a credentialing verification service. If you send your information in as it happens to a credentialing verification service, it's all on file and can be accessed almost instantaneously. The Federation of State Medical Boards, which is a compilation of all 70 medical boards in the United States and in some of our territories and islands, Puerto Rico, Virgin Islands, Guam, and Mariana Islands, all have medical boards. Why 70? Because some states have a joint osteopathic and allopathic board. Others have a separate board, like Arizona, and you heard about California earlier. So we provide a verification service. And there might be other ones out there, but being an officer of the Federation, I'm familiar with this one. And we've put a lot of time and money and effort into it, and we have a large staff working there. And as you obtain your degree or as you complete your residency, you send it in, you sign up with the service in advance, you send it in, it's on record, so 10 years from now, wherever you apply to Vermont or Maine, whatever, they can access it and get it. And you don't have to, where was I 10 years ago? Was I in this program or was I in that program, in this college or that college? And so it's wherever you go and whatever service you use, definitely use a verification credentialing service, because it's going to save you a lot of problems down the line. Well, we have, if you go to fsmb.org and you look for the FCVS, Federation Credentialing Verification Service, you'll click on it and it gives you all the information. And there might be other ones out there, like I said, but I suggest you really do it and get going on it, because it's going to save you a lot of headaches. I know, being upper management in the Supreme Court's administrative office of the courts, I get calls and complaints periodically about, well, how come it's taking me so long to get my bar license? And a lot of times the reason is, well, they applied for background checks and then they didn't include all the information or can't remember this and that. So make sure you go ahead and do something like that.
Yeah, like Dr. Praz and I, where we did our training, doesn't even exist anymore.
Yeah,
so
that's
another
big
problem.
point.
So there you go. So it's good that you have it in some repositories.
And they ask for, we ask for that. Yeah, and we go back to the employer, the hospital or whatever, and ask for documentation. And that coming in brings up a big good point. And if it's not there anymore, what do you do?
Yeah.
So it's a problem.
Any other board members? You got anything else you want to say? We've got Dr. Madam here. What are you guys going into? He's an ER, family practice. Go ahead.
I did have one more question. So this has kind of been more of a discussion in the United States for the last several years, but one-sided factor in both burnout and across the nation in physician hesitancy to seek psychiatric treatment for mental illness has been.
You can be a psychiatrist.
One of the commonly cited reasons for physicians delaying seeking such treatment is that on a very large number of medical boards, such questions are asked and they have to come in. How much utility do you feel that baseline diagnoses of something like depression or ADHD that exist prior in life really are validated by checking a yes box versus more serious diagnoses for schizophrenia or bipolar disorder that you would want?
I think it's each case is different, but we have changed our question because of that.
Yeah, that's a really good point, a
You
really
are
good
very
question.
intelligent
If
young
you want to
man.
speak to it, we just changed our license questions.
So now we have Marty's replacement of the time.
So it's much more general now. It's have you ever been noticed that you may have? Actually, you know what? I'll just read you the question.
While he's looking for it, I'll tell you that the Federation established a work group on physician burnout and mental health, chaired by a physician in New York who used to be the president of the Federation. And by the way, the president of the Federation now is the former chair of this board.
And he's the treasurer.
I'm the treasurer.
First time we've ever had two people from one board running the Federation.
I tell him I control all his money. He can't do anything as president unless I say it's okay. But we looked at that, and you raise a really valid point, and we did make recommendations on, number one, physician burnout, and number two, among other things, the application, as Justin will read to you, and we changed the application, working with the Osteopathic Association, the Association of Physicians,
and the MD board changed theirs too.
And the MD board too, based on the Federation's recommendations.
Did you find it, Justin?
I have the old question. I don't have the new question.
Just generalize it, what you remember.
The old question was, have you been diagnosed with a developing or initially or worsening symptoms of a condition? The new question is more general, saying, have you put on notice that there may be something that impairs your ability to practice?
Currently impairs
It has
you.
to be current.
Currently impairs you.
Current, not in the past.
Yeah.
Yes.
So there you go. You got your answer. All right.
Do any of you want to practice law after sitting through this today?
Any other questions you guys have?
Smart guy.
All right.
They're actually right in the middle of just starting.
You guys,
This would not be a good time to
second
decide you want to do law.
Okay, good. Well, maybe I'll see you guys on some rotations. Good luck to you guys. I hope you learned something this afternoon. Take care.
Bye-bye. There are not.
Yeah, it should be.
There are not.
Maybe
It is
Gene
a
and
good
I
thought.
must decide to practice law one day.
There's an MBA MD. I don't know, is there an MBA DO?
I don't think, we need to look at that.
My brother-in-law is a DOJD.
Is he really?
They go to school.
But he was a lawyer first.
Yeah.
And then he went back and went to school.
Can you imagine?
Yeah, he is crazy.
Overachieving.
I think you told me about him.
He's actually still in debt.
So are we ready to go to 12?
You're ready to go to 12.
Go ahead and talk to us about this, Justin, because somebody's got to go to tennis.
My daughter won her first match, so
good.
she's playing the number one seed.
All right,
So,
go ahead.
12A addresses the issues of, in statute, there are certain items that, at the delegation of the board, the executive director has the authority to do a certain item. So we, in consultation with the Attorney General's office, and I feel it may be best to review those statutes and reaffirm that authority every time you have a new director. So I thought that it would provide some clarification about what authority that is. So if the board would like to review A1 through 7, and then make a motion.
And we've run this past Gene already. We were here Tuesday night. We took out a few things, and I think you're happy with it now, Gene.
Number 6 is the authority to close complaints resolved through mediation, and I really have no idea what that is. We haven't done it before.
Do you want to just remove that then? I don't know what mediation is. I know at the AG's office you have mediation.
I know what it is. I don't know what it means in context with this board.
So, I don't know. Would you rather
I would
have that?
suggest
Just to pull it?
removing it.
Okay.
So let's remove 6 if that's okay. All right. Anything else that you saw that there's any problem with?
There was something I did. This changed from when we first looked at it.
Yeah, because we removed some. Do you remember one? Anyway, you can look at it here and see.
Like to enter and sign consent
Right.
agreements without going to the board.
Yeah.
Was one.
What are we doing with the, well, it's B is the 3 review of 4.
Correct.
Okay. Well, I would leave 6 in if it's in our statutes. We don't use a mediation program. If we did, then we'd have to go back in and discuss it here. But if it's in our statute, and I attend your attempt in tailoring this is to just follow through the statute. Is that right, Gene?
No, the intent is to delegate this authority
Right.
to your executive director.
But you listed
It's
what
optional.
you listed what's in the. Did you list everything in the statute, or just certain things?
There was an original listing of everything in the statute, but some were removed, like the ability to just enter into consent agreements without bringing them back to the board was
Oh, okay.
removed.
Yeah.
All right, then I don't care about 6 either way.
Okay. Anything else?
So we leave it in or take it out?
Don't care.
I'd take it out.
All right.
Let's just take it out. Let's remove 6, everything except for 6.
Okay.
You have to have a motion to accept this?
So a motion to delegate the authority stated in number 1 through 5 and number 7 to the executive director.
I make that motion. It's just stated by...
Second.
I got a second from Mr. Berg. All in favor signify by saying aye.
Aye.
All opposed, same sign. Now, where would you like us to go?
Okay. 2B is the investigation process, or 3, reviewer committee and executive director dismissals policy. So meeting with Mr. Landau and Jean and Mary, we looked at what our statute says and how we should be processing complaints through the 3 reviewer committee. Within the discussion, an attempt to streamline the complaints process, we thought, based on the statute, if the board delegated the authority for dismissing certain complaints on the recommendation of the investigative staff or the internal medical consultant, then those cases did not need to go to the committee review and be reviewed by the committee for dismissal. The other change through this policy would be that the committee meetings would actually be a committee meeting. Cases would be reviewed in open session, whether that be in person or telephonic, and then they would make a recommendation during the meeting rather than an independent review outside of the meeting.
Does that keep us keep us more compliant? Is that what you're looking for, Gene?
Yes.
So I don't have an issue with that. It's just that how do we do these? How are we going to do these telephonic meetings? Are we going to do them monthly? Are we going to do them?
It would depend on caseload, and we can look at what that structure would be like.
Okay. Because for all of us, it's like herding cats.
And the other option would be is hopefully you would see less cases because of how they're being managed.
So maybe we might even get by quarterly or something like that?
Correct.
Okay.
I'm still not quite understanding that part of it. Right now we have 3. If we all say dismissal, the case is dismissed, and we never see it, except for when we're in the board meeting, we say this is for dismissal.
Right.
So if we get 2 out of 3 who want an investigative hearing, one says no, then the idea is that those 3 reviewers get together and talk about it. Is that my understanding?
It would be similar to that, or it could go straight to that investigative hearing.
Yeah. I just want to be clear on how this is going to move forward, because I'm just a little.
Well, we have to make a change because what we're doing now we're not in compliance. Okay. So that's what the issue is.
Okay. So what do we have to do to be in compliance?
So we convene a meeting of Committee A and or B, whatever time is convenient for the members. You gather at that time. You would have done your work ahead of that meeting time, just like you do the board.
Right.
But you come to the meeting, you call the cases, you think this should be dismissed, this should go to initial case review, and then you vote on it. And that action then is taken. It's either dismissed, depending on the vote, or it's moved forward in some way. We just do it at a meeting.
In an open meeting forum. That's what they're looking for.
Which can be telephonic.
Right. Yeah, and it's an open meeting forum because how we're doing it now, they say it's like we're doing it in a closed meeting forum, and we're not complying with the state.
That makes sense.
Okay.
I have 1 or 2 questions. I like the idea, first of all. maybe because I was part of talking about it.
Because it's your idea, that's why you like it?
No, it wasn't my idea necessarily. But
that's what I got.
Complaints that are recommended by the investigative staff. Is investigative staff defined anywhere?
Investigative staff is defined, is not defined, but we could define it.
So we have to clarify what investigative staff is.
Okay.
Outpatient consult,
who it
inpatient
is.
consult.
Would it be OMC?
Yeah, or the board's medical consultant.
Shaking your head, Gene. What?
We spoke about this. It would not be the outside medical consultants. They don't have a say in what you do with the case. They provide their opinions based on what's provided to them, but they don't recommend what action should be taken.
Okay.
So,
But it's the investigative. You have to. Who is investigative staff? John, is that who you're getting at?
At this point, we only have one investigator, so I would term that as investigative staff, as well as the internal medical consultant. So it'd be Dr. Pra and John.
That's my second point. So if you say that for complaints that are recommended for dismissal by the board's investigator or the board's medical consultant, should the board's medical consultant be involved in every case in that regard? Since we're a medical board, so should complaints that are recommended for dismissal by the board's medical consultant or by the consultant and the investigative staff?
Can't you? Well, okay.
Or maybe after consultation with the board's medical consultant.
Well, don't you think that, John, I get what you're trying to say. If there's medical stuff, I think everything should be shuffled off to Dr. Pra. If there's DUI, abuse, whatever that kind of stuff is, non-medical stuff, they're not doing their application right, I don't see why John can't do that. You know what I'm trying to say? Why does it have to be run by Dr. Pra?
No, that's fine, but I'm just wondering about,
it could just be in
overlap.
Yeah.
It just could be in consultation with the appropriate
if he feels like it.
Staff.
Yeah, so John, you've done that lots of times. If you've looked at a medical, you think, hey, you know what, this should have really gone to you. What do you think of this case? You know, I've looked at it.
And that's what I started to say.
Okay.
Yeah, for dismissal by the board's investigator in consultation with the board's medical consultant if necessary, or the board's medical consultant.
Perfect.
Because John, leave that up to John to decide what to do.
You're not retiring on us, John. Stop it.
Not anytime soon.
Yeah. Okay. And my second point is bullet point number 2. I would like to add or a complaint in the medical judgment against a person licensed by the board or a person licensed by the board is convicted of a felony.
Okay.
Or can we add or applicant?
Yeah, on both. Yeah, we need to do both. But like, applicant wouldn't have a malpractice. You might could as a resident, I guess.
Yeah.
Yeah, I would add applicant for both. And let's see. And then we refer the case to. So basically, the idea, Gary, is that I think what we talked about is we kind of reversed the process. Just in consultation with Barb and John, they get it first, and they either take care of it themselves, and we don't see it at all. But then if they refer it to us, then we have to go ahead. The 3 reviewer committee meets on it, and then we decide what recommendation we're going to make to the entire board. Because the way we're doing it now is, say, Committee A meets, and the board, the other 4 board members never really have a say in that. They can pull it if they want, but they may or may not have read it.
That's right.
So this way, we make a recommendation to the board, so the entire board will weigh in on it.
So A and B would be involved together then? is what you're saying.
Basically, the A and
We
B
have a
will.
phone conference, A and B are all involved.
Well, the telephonic conference will just be between the individual boards.
Okay.
Say A has a case, and A decides, I'm going to recommend to the board that this case get dismissed. So we take it, we then set it for a board hearing, a board meeting, and then as the chairman of A, I'll present the recommendation and discuss the case, and the board will vote. So the board gets to vote. And my other part of this, I don't know if we need to put it in or we can handle it informally, is that the chairman of each committee should assign the cases to the other committee hearings, kind of like the Chief Justice assigning the cases to the justices to write. So someone's going to have to present it to the board. So the chairman can say, okay, Mr. Berg, you go ahead and handle this case, or Dr. Cunningham, you go ahead and handle
you
that
looked at this case. What do you think?
Yeah, and we can do that informally, I guess.
Just a point of clarification. You're talking about the committee presenting the particular case to the board after their recommendation?
Yeah.
Okay, thank you.
Because one of the committee members is going to have to present it.
Yeah.
Okay.
Yeah, lots of boards do that.
Yeah. And basically split it up. So that's the idea. So it's kind of reverse of what we're doing now. But the whole board gets to weigh in.
Yeah, because, I don't know, I remember getting, a case to decide on dismissal or to investigative hearing, and all it had was an outside consultant report.
Yeah.
And so we won't have that anymore. We would have
No. We'll still have the outside report.
Yeah.
We'll still
right,
have
but it was, I never saw Barb or John.
Right. Yeah.
Right?
Yeah.
So that's what I'm getting. I'm
you
struggling
still
with
have
that
those.
because.
Yeah.
You'd get the same facts. We
It'd
wouldn't
still be the same information that you're getting now.
Yeah, but their name would be assigned to it.
Not in all cases. No.
No, we'll still get outside committee, outside investigator.
Yeah, because then we don't want to double work, right? Because I don't want.
They're not going to review everything. They might.
Yeah.
They might, but in some cases.
That's what I'm worried about too.
We only get the cases that the committees only get the cases that Justin sends over to us. If 100 cases come in, and Justin may end up, after going through his process, decide 30 should go to a committee, then he'll send 30, split them up, and each committee gets 15. And the other 60 he's already taken care of by dismissing it.
Okay.
Instead of every case coming in split between the two committees,
Got
and
it.
then we make a recommendation.
That kind of streamlines it a little bit, doesn't it?
Yeah, you're right.
Okay.
Do we have
And
to,
we're in compliance then.
do we have to
When's
vote
the goal
on-
to start this?
Yeah, do we have to vote on this?
You do have to approve it.
Yeah.
So,
I'll make a motion for approval.
I'll second that. All in favor signify by saying aye.
Aye.
All opposed, same sign. Now what?
Okay. On to tab or 12C, substantive policy statement, board certified in pain. Before I started, the board had directed staff to draft a substantive policy statement regarding clarification on the board certified in pain. I have drafted that substantive policy statement. The board just needs to review it and determine if it's acceptable, and if it's acceptable, then you can approve it, and I will file it with the Secretary of State's website and post it on our website.
And we had run through this before.
Correct. This was the language that was prescribed by the board in consultation with the Arizona Osteopathic Association.
Right. Do you have any issues with it?
No.
Can I have a motion then?
Motion to approve.
Motion to approve. I'll second that. All in favor signify by saying aye.
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 All opposed, same sign. Thank you. Next one.
12D, similar situation. Staff was directed to draft a substantive policy statement regarding CME and what category is acceptable for the opioid prescription legislation to meet that 3 hours. The board determined that both Category 1A and 1B of courses designated by the American Osteopathic Association, as well as the American Medical Association, are deemed as acceptable to meet those requirements. If the board finds this policy acceptable, then I will submit it to the Secretary of State and post it on the website.
We added the AMA. Isn't that right? Yeah.
Correct.
All right. Can I have a motion?
Motion to approve.
I'll second that. All in favor, signify by saying aye.
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 Okay. All opposed, same sign. All right.
12E is universal licensing recognition. I will read that. So, HB 2569 modifies ARS 324302 and provides an additional path to licensure that has been entitled universal recognition for applicants who have had their license in another jurisdiction for more than 1 year in the same discipline and at the same practice level, and are establishing a residence in Arizona. As staff prepares to implement and the modified statute, which becomes effective August 27, 2019, we are requesting the board provide guidance on the process of granting licensure under universal recognition. Listed, we explained what we would require from those type of applicants that are applying under universal recognition. And then specifying through a substantive policy statement what would be acceptable in determining establishing a residence, so that they would meet that qualification. And that policy statement information came from the Attorney General's office as a recommended process. And the last part was, the general effective date was April 27th of this month.
Okay.
Justin, I'm skimming through it because I didn't get a chance. I'm just seeing it. Can you email this to me? I know we're going to pull the agenda off our website. Okay. I'd like to go ahead and read it. We need to pass it because it takes effect August 27th, but I'd like to read it and may come back next month if I have any questions.
Are you okay with us making a motion to pass it?
Yeah, I'll so move.
So move. I got a second. All in favor signify by saying aye.
Aye.
All opposed, same sign.
But you want it back on the agenda next month?
No, I just want to get a copy of it. Okay. If I have any questions about it,
just clarifying. Okay.
Yeah, I will go ahead and ask it be put back on.
Okay. Then 12F is data waiver eligibility policy in accordance with ARS 32-1803A7. So this was a statute change this year in the legislature regarding the board's authority to determine educational courses or experiences that qualify for having osteopathic physicians to be eligible for the waiver with the DEA. The DHS was the one that drafted the legislation. We have drafted an internal policy on how we would handle approving those courses and presenting them to the board. Staff is asking that the board approve or direct staff to adopt this policy and put this into place for moving forward.
Okay. Any questions from anybody?
This has to do with. It has to do with the training that they're going to. Correct me if I'm wrong, but the training that they're planning to do in the medical schools for Subutex and Suboxone prescribing.
Remember we had that before. Remember that?
Remember how you have to go through a certain amount of training in order to become
yes,
to get that part on your DEA.
That's what this is.
They're going to do it in the medical schools now, and so it's a way for us to get more and more physicians that are able to
prescribe it.
Prescribe it, yeah.
Right.
And they would essentially be able to do it right after graduation,
yeah,
or as soon as they get their license.
Yeah.
It's because they've completed the training prior.
Yeah. Yep.
It's a data waiver.
Okay.
Yep. Can I have a motion? Can I have somebody make a motion?
So move.
So move. I'll make a second. All in favor signify by saying aye.
Aye.
All opposed, same sign.
Sorry, getting tired.
That's okay. We're all tired. Are we ready to wrap it up?
We're getting very, very close. The last thing I have, 13A and B for the Executive Director's report. We had 4 cases dismissed by the committee in June. We have, of course, the cases that were dismissed this morning. What I wanted to highlight for the board is, as of August 1st, we only had 1 pending case that we were in the process of opening, sending the notice, all of that. As of Friday, the investigative staff had 0 pending complaints. So we've opened all of them. They're now in the investigation
compared to what we were.
Oh, yeah.
Oh, God, yes.
Isn't that crazy?
So I will.
Good job.
Thank you.
Good job, staff.
Staff has been working very hard. I believe as of February we had 99 that were pending to be opened. So we 102. Sorry, there we go. So we've now
Very
gotten
good.
through
Way to go, staff.
that backlog.
Awesome.
We will now begin to work through the open cases that are in the investigation phase. Thank you for adopting the 3 reviewer committee and the executive dismissal policy. We will be able to get through those rather quickly, I believe. Just an update on last year's budget. We ended the fiscal year. We did not spend out our entire appropriation because we were able to make some of those savings. We did exceed.
I thought I took care of that.
We did exceed our expected revenue, so we did bring in more revenue than we expected, so that's a good thing. And I will give you an update on next month's budget next month.
Higher revenues, lower expenses. Wow.
Don't tell Mark. He's going to expect that at home.
I know everybody wants to go, but I just want to know how these kids are going to be educated. Is it just a classroom kind of thing, for the Suboxone and all of that, or is it a rotation?
I believe it's an actual course that's being put together by DHS. It's in conjunction with DHS and the medical schools, and they're putting together programs so that these students can have data waivers when they graduate, and then every single student that graduates in Arizona will have a data waiver and be able to prescribe if they so desire.
Okay.
I had a quick one fast item on Dr. Skousen. Maybe it has to go on to September's, but is there any way that we can allow him to do that telephonically to come back? I mean, he did come back once already. Do you want to make him fly out here again?
I do.
He already mentioned that he's having,
I get it, but
Does it maybe depend on what the evaluation says?
Well, let's just see what it says. But this guy has some bad issues, man.
Okay.
Yes.
We don't want to talk about it.
If you read the complaint,
I read it. I don't know what we're.
I like to see him in person, really. I have to tell you now. I get what you're saying. I appreciate it. Appreciate it. If you read the original, did you read the original complaint of this guy?
I did.
Okay.
So just to wrap up the licensing, just wanted to highlight through the end of the fiscal year of 19, as from April 15th to June 30th, we issued and approved 129 licenses. From July 1st to August 1st, we issued 56. We received 401 applications last fiscal year. We've had 20 so far this year. Our average days that we're spending per application is dropping. Went from 94 to 60. Now August 1st, we're at 45. This number is outdated. August 1st, we had 6 licensure applications to process. As of Friday, we have 0.
Wow.
So all applications have been open. They're going through the process.
You're right. That is
Way to go to the investigation.
It's you and Melissa. Yeah.
Done a fantastic job.
Yeah. Can you believe it?
My entire time on the board, which has only been just a couple years, I've never ever remember anybody telling me these numbers.
We need to thank Justin and Barbara.
Yeah. Mostly Justin.
Thank you guys.
Thank
Good
you.
job.
And all the employees too.
Staff.
Yeah, you guys.
And staff. Fantastic.
You guys did more than you normally should have to, so thank you.
And then the last item that I have is the average time for issuing orders of the final action of the board is about 3 days after the board meeting. So usually by Wednesday, it's all wrapped up.
Good.
Yeah.
Thank you.
What do you do the rest of the time?
So that's everything that I have. I have nothing to add to the licensure update, or the legislation update. If there's any questions, I'm finished.
Ready for adjournment?
I have 1 or 2 things.
Yes.
1 or 2.
Justin, actually, Justin, I guess me through Justin, received a request to speak to the Arizona Telemedicine Association about the Interstate Compact. I am going to be out of the state at the time, and I emailed with Barbara, and we thought maybe, Justin, if you feel you can, could you do that?
Absolutely.
Okay. I'll let you I'll send a note, Dr. Weinstein, indicating you'll contact him, because he knows I'm going to be out of state.
Okay.
So if you could do that. I've also, which he's already doing, suggested to Justin he get involved in AIM, the administrators in medicine. He'd be a great representative for our board. And I'm going to go to the FSMB lawyers board attorneys workshop in November. Maybe Gene, you could come too, if you can.
Let me know.
Yeah, there is funding for it, so yeah, if you can go, that'd be great. And it's in New Orleans. It's actually literally the day before we leave for Israel. And let me see if there's anything from the Federation. We're meeting with the pharmacists and the nurses, national pharmacist boards and national nurses boards next weekend, and I'll let you know if we get any information from there. I'm also attending the American Legislative Exchange Council this week. It's a conservative legislative group. Get some really good information there. If I hear anything on healthcare, I will let you all know. And we have meetings in September, October, and November. Is that correct?
Mm-hmm.
All right, we're all good for September 14. That's our next meeting, the 14th.
I'll be there.
Yep.
You won't be here. You'll be gone. All right, you guys. Motion for adjournment.
So moved.
All in favor, saying aye. Second. All in favor, saying aye. Hey.